Abu Dhabi Health Services Company PJSC, SAHA, is an independent, public joint stock company created to develop the curative activities of the public healthcare system in Abu Dhabi. The company owns and operates all the public hospitals and clinics of the Emirate of Abu Dhabi. SAHA is a pure health asset, the UAE's largest integrated healthcare platform. SAHA is committed to continuous improvement of customer care to recognize international standards and providing the community with world-class health care. SAHA operates 14 hospitals with over 3,385 beds, 70 ambulatory care, family care, and urgent care centers, and 3 blood banks. Its facilities accommodate 117,162 inpatients annually and conduct 43,262 surgeries, as well as treating more than 5 million outpatients. SAHA is one of the largest integrated healthcare providers in the Middle East, with more than 14,000 doctors, nurses, ancillary care, and administrative personnel. Learn more at www.saha.ae.
Underway, I'd like to invite Dr. Saleh, who is our ECMO Task Force Chair, and Dr. Sama, his co-chair, to come up and officially open our workshop. This is the second of the task force workshops we've held. The first was held in Cleveland Clinic in May, and this will be the first purely pediatric ECMO workshop that's been held in Abu Dhabi. So it's a national first for National Day weekend. So over to Dr. Saleh.
Thank you, Dr. Mark. Good morning, everyone. Thank you so much, and happy National Day to all of you. As you all know, National Day is not only for Emiratis. We all consider you as part of the UAE. So happy National Day. Enjoy it with your family, and we wish, inshallah, more and more to the UAE and the region. I would like to thank Dr. Mark for the kind invitation, Dr. Salman, also for co-organizing this wonderful and important workshop. As a Department of Health, we are very committed to support such life-saving measures, upskilling and making sure that Abu Dhabi and the UAE, and also supporting the region in such an important, procedure. We are very committed, and the support is very available when needed. What we are creating from our side is an asset that it should be available, and we've experienced it in COVID. Many lives were saved, but unfortunately many lives were lost because we could not offer them ECMO at the right time. So what we want to now is learn from what happened in COVID, restructure the system from our side. So we're investing on pre-hospital care. So much now we're investing on co-organizing and coordinating the system. So we don't want you as clinicians to waste time in calling the system. So we're trying to take that burden from you. If you feel this patient needs an ECMO, we do the work for you. Okay, and through certain pathways that we will work on. And then somebody will come, hopefully, and take, or the retrieval team will go and retrieve the patient. So much, inshallah, coming down the line. I see it very positively from a government side. Seeing all of you in a weekend, in a long weekend, reassures me personally that there's so much commitment, and this is not surprising. We've seen it during COVID and even before COVID from all of you. This is, if we say we are saving, I'm an emergency physician, so we work hand in hand with you. If we want to save lives, this is exactly, I think, what will hopefully save lives. And the stronger, the more organized we are, the more lives we're going to save together. And believe me, we will be, we've been discussing this, we can be a hub, a known international hub for ECMO, where people will fly one day and will learn from you how to establish their own systems. So I've done this from an emergency medicine point of view. Back in 2012, we established the Emergency Medicine Society. And if you ask me then, 10 years ago, whether you will really see emergency medicine as a specialty in the UAE, I was never able to imagine at the time. But because we really got together, delivered multiple system restructuring, now emergency medicine in the UAE and in the region and internationally is known. I was telling the team also, I've been asked to chair the International Federation of Emergency Medicine. When somebody called me from a big country, would you consider yourself a president? I was honestly shocked, because we always look at ourselves in the region that, somebody else is better than us. And this shifted the way we've been thinking, that one day ECMO in Abu Dhabi should be and will be, inshallah, one of the international landmarks of ECMO globally. Because we are a small community, we're very organized and inshallah getting to be organized, and we have the skills. So we have the manpower, we have the talent, so let's make it happen. Anything we can do from a Department of Health, please let us know. And keep up the good work. On behalf of the Department of Health, on behalf of the government, I want to thank every one of you for your commitment. I know you're leaving your family, your kids, they need you during this long holiday, but think of the patient that we will save, or patients that we will save one day, and all of this, I think, will come second. So thank you so much for inviting me, and good luck in the course, and let's keep the communication going. Thank you.
morning, everyone. First of all, I would like to thank all the group who showed this clear commitment to attend for this workshop and to learn about the ECMO upgrading skills and knowledge in this venue. I would like to thank Dr. Saleh Ali for coming also on the weekend and during the National Day to attend for the opening ceremony of this workshop, and to thank for his keen support, to lead the ECMO program in Abu Dhabi, in addition to enhance the workshops skills here in this venue as well. I would like to thank the government for supporting education in all aspects, not only ECMO. I see all the conferences now are going to move forward after the COVID-19 pandemic, and after a few days we will have the Emergency Society Emergency Medicine Conference. So we are having more tasks now. I think we were talking about adults. The more critical part is saving lives of kids. So it is very painful to know one kid had, died because of a salvageable condition. So, take this opportunity to learn, take this opportunity to upskill yourself in ECMO, and hopefully that we will start the ECMO program upgrading in Abu Dhabi, and then we'll start the retrieval program here to save more lives, whether in Abu Dhabi or the other parts of the United Arab Emirates. I would like you to enjoy the 3 days of coming here, and thank you very much.
Thank you. Good luck with the course. Thank you.
Okay. So after the formalities, we'll get our didactic session underway with our first speaker, who is Dr. Kesava, my one-time colleague from SKM. He was a fellow in Melbourne, Children's Hospital, Royal Children's Hospital, Melbourne, and consultant in Southampton before we worked together in SKMC, and I'm very happy to invite him to open the session.
Thank you, Dr. Mark, and I would like to thank the ECMO Task Force, Department of Health, for inviting our team to be part of this wonderful course. I'm sure you will all have a good time and learn a lot, and together we will make ECMO happen. So, being the first speaker, I thought it would be a good idea to include some slides about basics of ECMO. Some of the slides in the beginning may be very basic for many of you. Please bear with me for 5 minutes. The gist of the talk will be on patient selection for VV ECMO in neonatal age group and in pediatric age group. So ECMO stands for extracorporeal membrane oxygenation, which basically means the oxygenation is done outside the body. Essentially, the basic is that you drain blood from the patient using a pump, and you oxygenate it and put it back into the patient. That's all it means. It can be used in 2 different configurations, veno-arterial and veno-venous ECMO. Veno-arterial ECMO is when you drain the blood from the venous side, and after oxygenation, pump it back into the arterial side, into the systemic circulation. Usually the drainage is from right atrium or one of the big vena cava, and the return is to aorta or one of its big branches. This form of ECMO, the blood bypasses both the lungs and the heart, and the ECMO pump provides flow to the systemic side, therefore contributes cardiac output. This kind of ECMO is used when there is cardiac dysfunction. It could be a patient in respiratory failure who has cardiac dysfunction, or a patient in cardiogenic shock, or a patient who is in cardiac arrest situation. Typically we aim to drain about 70, 80, 90% of the cardiac output through the pump and pump it back onto the systemic side. Veno-venous ECMO is when you drain from the venous side and return to the venous side. This form of ECMO does not provide any cardiac support, so it's mainly used for respiratory failure. The indications for ECMO, as you know, are severe respiratory failure or cardiac failure that is not responding to conventional therapy, or a patient in cardiac arrest situation. Why do we use ECMO? ECMO can support oxygen delivery to the tissues. In the VA ECMO format, it can oxygenate, remove carbon dioxide, as well as contribute to cardiac output. On the veno-venous ECMO, the blood can be oxygenated and CO2 can be removed. This enables us to wean damaging therapy like mechanical ventilation or a very high inotropic support, which may be impairing myocardial recovery. So it buys more time for the patient to recover from the underlying illness. For example, with veno-venous ECMO, you will be able to remove CO2 very efficiently, even with 25 to 50% of the flow, and oxygenate the patient as well effectively. Once the ECMO machine takes over, then you can wean the ventilator. The minute volume that you need to give to the patient will be much less than what you are providing before ECMO. You will be able to wean the respiratory rate, tidal volume, FiO2, and also PEEP if you need, if it's very high. What are the limitations? The ECMO is time limited. You can only provide it for a few weeks, maybe a few months at most. It's so you need a patient who could potentially recover in that time frame, or you have a exit strategy or other treatment which can help you wean the patient of the ECMO. It's very invasive. It has got potential complications that can be life-threatening, and it's very resource intensive. So what are the strategies we can use ECMO? The most frequent strategy that we use is a bridge to recovery, where the patient has an acute illness and the patient can recover from it, but the patient is in multiple organ dysfunction. There is compromise of tissue oxygenation. So ECMO can be used as a bridge to recovery. In severe cardiorespiratory failure, the end-stage heart failure, end-stage lung failure, you may use it as a bridge to transplant if a transplant program exists. For severe cardiac failure, end-stage cardiac failure, you could also use it as a bridge to, destination devices that can be implanted for longer term. In CPR situation, we use it as a bridge to decision, in that to prognosticate on the patient, and depending on the patient's prognosis, then you will proceed with the decision about what to do with ECMO. I just wanted to highlight that most of the data that all of us will be presenting during this course is from the ELSO database. ELSO is a non-profit organization and a consortium of healthcare organizations, researchers, and so on. They maintain a very detailed database of ECMO patients, and a lot of research and guidelines comes out from that database. As of now, we know as of 2021, there were about 543 ECMO centers reporting to ELSO. This is voluntary basis, so there are probably a lot more ECMO centers not reporting, and over 17,000 patients, patient data was submitted to ELSO. So as you can see, ECMO, the number of centers and also the number of patients being treated with ECMO has exponentially increased. It started off with the H1N1 pandemic, but it's also had a bit of an impetus from the COVID-19. What is the prognosis for ECMO patients? The respiratory ECMO patients have better prognosis than cardiac ECMO patients across the age group. The neonatal respiratory ECMO patients by far have the best prognosis among the patients being treated with ECMO. About 800 to 900 neonates are being treated every year with ECMO. The patients are submitted to ELSO database. Probably there are a lot more being treated with ECMO. Pediatric respiratory ECMO is also increasing in numbers. So how to select a patient for ECMO? That is a very important thing to understand. There is no universally accepted criteria. Most centers select the patient based on discussions and consensus between the ECMO physician, ECMO surgeon, and within the ECMO team. Essentially ECMO is a very invasive therapy, so it can cause life-threatening complications like intracranial hemorrhage and so on, which could itself lead to mortality. So if you treat a patient with a low mortality risk with ECMO, you may not see any survival benefits. The recommendation from ELSO is to consider ECMO when the mortality risk reaches 50%. ECMO is definitely indicated if the mortality risk reaches 80%. So if a patient, you predict the mortality is 80%, the patient will definitely derive a benefit from being on ECMO. If the mortality risk is above 50%, most likely the patient will derive a mortality benefit. One of the issues we have in pediatric and ECMO is that we don't have robust randomized control trial data to define mortality risk. So this is a study, I think it was published in 1996. It was from quite a few centers in the US. It was a retrospective study where they looked at all the patients with severe respiratory failure in the pediatric age group. They compared the patients who were treated with ECMO and patients who weren't treated with ECMO. They matched each patient who was treated with ECMO with a few other patients who had similar mortality risk, and what they found was that ECMO was beneficial for patients in severe respiratory failure in the pediatric age group. The interesting data is, if you look at it, the mortality, when the mortality risk is below 25%, ECMO was actually causing more mortality. You start seeing some benefit, a trend towards better prognosis when you use ECMO in 25 to 50% mortality risk group, but it was statistically significant when the mortality risk was between 50 and 75%. Once the mortality risk was above 75%, predicted mortality was above 75% in this study, the actual benefit started going down. So I think probably between 50 and 75% is the therapeutic window in which the patients would derive maximum benefit from ECMO. So what are the conditions in the neonatal age group for which ECMO is used? These are the 5 conditions that account for vast majority of ECMO treatment in the neonatal respiratory failure. As you can see, the prognosis is dependent on the underlying diagnosis. Meconium aspiration syndrome has by far the best prognosis, and congenital diaphragmatic hernia has the least prognosis in these 5 conditions. This was the first proof of concept study of efficacy of ECMO in neonatal respiratory failure, published by Dr. Bartlett's group, and that is the Esperanza. She was the first neonatal baby treated with ECMO for neonatal respiratory failure. They had the first 50 cases, they were like moribund children who the neonatologist felt definitely would not survive, and they put those patients on ECMO and they achieved a 54% survival rate. And when they started using mortality risk assessment, and when they could predict 80 to 100% mortality, the survival was 90% in the next 50 patients. However, it was a case series. There are few randomized control trials. By far the largest one is done by the UK Collaborative Group in the UK. They selected patients with oxygenation index over 40 or PCO2 over 12 kilopascals for over 3 hours, and they chose gestational age 35 or above with a birth weight of more than 2 kilos. So the patients were selected from the neonatal units that were kind of well established in managing neonatal respiratory failure, and they were randomized to receive ECMO, and if they were randomized to receive ECMO, they were transferred to one of the 5 ECMO centers in the UK. What they found, the trial was actually stopped after interim data analysis because ECMO was beneficial. statistically significant mortality benefit was there. As you can see, the mortality in the ECMO group was half of what it was in the conventional treatment arm. And the survival was neurologically intact survival. It wasn't, brain damaged kids that were surviving this ECMO. But the difficulty in applying this trial to the current era is that at that time, nitric oxide and high frequency oscillation wasn't widely in use. As you can see, nitric oxide was only used in 20% of the patients and high frequency oscillation in 11% of the patients. We know that inhaled nitric oxide is effective in near-term infants more than 34 weeks gestation with severe respiratory failure. The ECMO use is reduced by 33%, and this is the meta-analysis of all the trials that's been done on the efficacy of inhaled nitric oxide in this group of patients. So we know that when we compare ECMO usage for neonatal respiratory failure between 1993-95 and 2014-15, there's actually a 33% decrease in the number of ECMO runs for neonatal respiratory failure that is being reported to the ELSO database. There is the hypothesis from the researchers is that there's been advances in technology, advances in treatment, advances in care, which has led to this decrease in the use of ECMO. For sure, inhaled nitric oxide, prevention of sepsis, and improvement in perinatal care has contributed, but there may also be contribution from use of permissive hypercapnia and high-frequency oscillation for neonatal respiratory failure. Another interesting fact is that the 5 conditions that we talked about used to account for about 95% of the patients treated with ECMO in 1993-95, whereas in the current era, they only account for 85% of the patients treated with ECMO, which means we are using ECMO for more complex indications compared to before. Consistent with this, the overall survival has decreased from 76% to 67% in the current era. So this is a very interesting slide for me. This looks at the diagnosis, the primary diagnosis, what's happened between the era. As you can see, congenital diaphragmatic hernia has now become the most frequent indication for neonatal ECMO. There's been a decrease in use of ECMO for meconium aspiration syndrome, respiratory distress syndrome, sepsis, and pneumonia. I think this may be because these are the conditions that are responsive to inhaled nitric oxide, maybe to high frequency oscillation, and so on. For sure, we know patients with congenital diaphragmatic hernia, the nitric oxide is not as effective in reducing the ECMO usage compared to patients with meconium aspiration syndrome. So I think when we look at the neonatal respiratory failure population, we need to distinguish them based on the underlying primary diagnosis. For example, you may have a lower threshold for ECMO in a baby with congenital diaphragmatic hernia because these patients have hyperplastic lungs. Any additional ventilator-induced lung injury, for example, prolonged ventilation, could alter the prognosis for these patients much more than a patient with normal lungs to start with, such as meconium aspiration syndrome. So this is the current ELSO criteria for neonatal respiratory ECMO. A child, a neonate with a severe respiratory under a cardiac failure and a high likelihood of mortality with a reversible etiology. What they suggest is you put the patient on ECMO when tissue oxygen and oxygen delivery is inadequate despite conventional management, or there is a sudden deterioration with poor recovery, PaO2 below 40, or on a sustained high oxygenation index, or severe RV dysfunction. To me, this criteria, suggests, the patients, if you take these patients who fit this criteria, probably it would define a mortality risk of 80%. And once you've hit this stage, it will be very difficult to transfer these patients to an ECMO center. You probably need mobile ECMO and cannulation in the referral hospital. Based on this ELSO criteria, most centers have an operational definition. This is one such definition I picked up from the New Zealand Starship Hospital. So this is their criteria for selecting patients. Before, we used to talk about maximum medical therapy, which seemed to suggest that ECMO should be used as a last resort. But more and more, we're talking about optimal medical therapy. So we should be considering ECMO when our therapy is starting to cause additional damage to the patients. For example, when we've hit a ventilator-induced lung injury threshold with mechanical ventilation, or we know that we're giving too much inotropes and flogging a tired horse in terms of myocardial function, we should be considering ECMO. So there are a few things that I would like to draw attention in terms of neonatal respiratory failure patients. Most of these patients are initially admitted to neonatal intensive care units, which are very well established for treatment of preterm infants. And the treatment options for a preterm infant with respiratory failure is limited. For example, ECMO is not an option when the child's weight is below 1.8 kilos or the gestational age is below 34 or 32 weeks. So quite often you tend to accept, because there is no other option, you may accept parameters that are outside of norm for those babies. And I'm sure, that will help minimize ventilator lung injury and survival in that group of patients. But when you come to a term baby with neonatal respiratory failure, we need to think hard about, how we apply, how we select the patients. Probably we need to select them when we know that our therapy is actually starting to damage the patient. For example, permissive hypercapnia is practiced widely in neonatal unit, but we don't have a clear data on the efficacy of it, and we don't know what the safe limits, safe thresholds are. So we should not be accepting CO2 of 100 or 120, we have to have a limit beyond which we are saying that the patient should be treated with ECMO. Another important thing is that this hyperoxic acute lung injury is less well appreciated. Very often, we tend to keep the patient on 100% oxygen, and that may, deliver oxygen to the tissues, but it will be causing additional damage to the lungs. We know that animals breathing more than FiO2 of 0.8 for 3 to 6 days, they uniformly die. Probably the safe limit for FiO2 is below 0.6%. When you keep the patient on FiO2 more than 0.6, you tend to have acclimatization with proliferation of alveolar epithelium. Quite often these patients will develop hypercarbia because there is a diffusion problem now induced by the hyperoxia. So this, again, we need to have a time limit. If the oxygen can't be weaned for 12 hours or 24 hours, we should be thinking about ECMO. Another aspect to think about is ventilator-induced lung injury. I couldn't find any clear data on what the thresholds are for ventilator lung injury in this group of patients. But looking at what is widely practiced, I put some parameters there which I use personally. If the patient is hitting this criteria, for example, peak pressure is 28 to 30 and it's not improving within 12-24 hours, then really you should be asking the question whether the patient would benefit from ECMO. I'm not saying you should put the patient on ECMO, but you need to review the whether ECMO is indicated at that stage. Again, in terms of optimal medical therapy, you need to have clear targets. You need to think about PaO2 of 50 to 60, CO2 less than 70, target FiO2 below 70%, because this is essential to avoid tissue hypoxemia. And it should, in terms of conventional management, nitric oxide, sedation and analgesia, paralysis may be useful, inotropic support may be helpful in stabilizing these patients. Important thing to notice is that the longer you ventilate the patient, the worse the prognosis. So this is a study, retrospective study, looking at the patients who were treated with ECMO. When you compare the patients who were treated with ECMO early, less than 96 hours, they were less likely to have chronic lung disease, and also the ECMO run was much shorter. So it's important that, for days and days, it's important to avoid high ventilator setting that could be damaging to the lungs. In terms of vasoactive medications, again, there is no recommended threshold beyond which you should be considering ECMO. But for me, if you're hitting epinephrine, norepinephrine doses of 0.5 micrograms per kilo per minute or above, then you need to be seriously thinking about ECMO. The congenital diaphragmatic hernia, those patients I think are very different to meconium aspiration and sepsis RDS patients, because they already have a hypoplastic lung to some degree at least, and ventilating them for a long period of time before putting them on ECMO could actually make ECMO ineffective. So these patients, we need to be more careful, and we need to think about ECMO much earlier than the other patients at least. Based on needs assessment, in the UK collaborative trial, 1 in 4,000 live births, patients required ECMO. If we take that number to UAE, we should be having about 20 to 30 runs of neonatal ECMO in UAE. But right now, I'm not sure. I think it's far less than that. There is underutilization. In terms of pediatric respiratory failure, we have now definitions for ARDS and diagnosis of ARDS and severity of ARDS. In terms of mortality, the severity of the ARDS at presentation may not be a good criteria to select patients, but this was a study looking at the mortality of various definitions. As you can see, the PALIC definition, even when the patient had severe ARDS at presentation, the mortality was only 31%. However, if you looked at what happened to that patient in the first 24 hours, then that is helpful in determining the mortality of the patient. So if the patient presented with mild, moderate, severe ARDS but got worse over the first 24 hours or stayed persistently severe ARDS for the first 24 hours, then those are the patients who hit a mortality of 60%. So those patients, you need to be thinking about ECMO. In terms of pediatric patients, one of the things is that you need to track the severity of respiratory failure. You need to be using objective measures like oxygenation index or oxygen saturation index to track the severity of it. Consider gas exchange in relation to the current level of support, whether you can optimize the ventilator parameters, whether you can add in any rescue therapy like prone positioning or high frequency oscillation or inhaled nitric oxide, which could improve your patient's condition and enable weaning the ventilation to safe levels. And duration of mechanical ventilation is important. The longer you've been ventilated before you go on ECMO, the worse the prognosis. So in terms of respiratory ECMO indications, again, they are similar to neonatal population, oxygenation index more than 40, severe respiratory acidosis that is could not be treated with conventional therapy, lack of improvement from rescue therapy, risk of ventilator-induced lung injury, and significant air leak. The exclusion criteria, again, any lethal malformations or severe neurological compromise before ECMO, allogenic bone marrow transplant patients below 3-6 months after transplant, an incurable malignancy or absolute contraindications. In terms of prognosis for pediatric respiratory ECMO, the survival is about 60%. Most of the conditions tend to have survival around 60 to 70%. So in summary, also ECMO is a standard of care for neonatal respiratory failure. There's no universally accepted criteria for ECMO initiation. Most of the centers select patients based on individual risk-benefit analysis based on consensus within the ECMO team. It's important to track the severity of respiratory failure establish clear guidelines for your target parameters and prevention of ventilator lung injury. Discuss with ECMO team early because logistics of ECMO provision is complex. Until mobile ECMO is easily available, you should be thinking about referring the patient to ECMO center when the oxygenation index hits 20 to 25. Thank you.
We have some time for questions if anybody has anything.
So Kesava, we all know that even if mobile ECMO is available, transferring patients who may not need ECMO to a ECMO center achieves better outcomes than leaving patients where they are. I think Chris will attest to that. I think there is a lot of adult data to support that. With the Caesar trial, I don't know if the pediatric population is very similar. Mark is smiling, so I'm sure he has several anecdotes where this would be applicable. So the first thought that comes to my mind is, of course, to DOH in terms of collaborating to achieve ECMO across the state. Shouldn't we be also thinking of transferring patients who do not need ECMO, but perhaps are patients who may need to make that decision transferring? So over triage in these patients is completely justified, I think, and this is what we've all experienced in various centers around the world.
I think, the first thing to say is that sometimes patients deteriorate suddenly. So mobile ECMO, may be required in those cases. If you're thinking about transferring a potential ECMO candidate to referral centers, then that needs different kind of logistics, in that you need to have a critical care transport team which can retrieve the patients with capability for inhaled nitric oxide and so on. Also, you need to have the capacity in these units to accept those patients when the referral is made in a timely fashion. So I'm not sure which is best. In the UK collaborative trial, actually 84% of the neonates who were randomized to get ECMO and transferred to the ECMO center received ECMO. And about 10% of patients died. Only a very small proportion of patients who maybe less than 5% of the patients actually improved and did not need ECMO. I know that in the adult trials, for example, in Caesar trial, it is seen that the management in the ECMO center could have contributed to the better outcomes, and it may be the same with the neonatal or pediatric patients also, but it needs a different kind of logistics.
I think it's a very good point you raise, and the transport infrastructure currently available for critically ill neonates and children is part of the process that we are involved in. Pediatrics is another of the lines in the CPAR task force. So yes, we need to develop both in parallel. I would agree.
Yeah, sometimes it's not about moving the patients, it's about having that discussion. So the patient's there, you can often give advice, plan ahead, put lines in the sand where you're going to activate and when you're not.
I receive many patients from many centers who are thinking that they are unable to manage those critical patients. But I keep always them in open phone call for most of the time, even at midnight. And this was solving a lot of issues regarding the transfer in and transferring out. And selection of patient going to the ECMO is really challenging in neonates, but even more challenging to transfer a critical neonate from a unit to another unit, especially if it's from large distance. So we have to keep in consideration any simple deterioration in a neonate who has oxygenation index more than 20, just because of transfer you can lose this baby rather than helping this baby. So the window of transfer should be selected properly for this patient, and the reason should be optimal for the transfer.
Thank you, Dr. Chris and Dr. Adeeb. So thanks very much, Dr. Kesava. To introduce our next speaker, I'm delighted to welcome Dr. Chris Harvey from the UK. He is ECMO Director in Glenfield Hospital in Leicester and has a very big experience of transporting critically ill neonates and children. on ECMO, and I had the pleasure of working with him whilst we were in Leicester together. So over to you, Chris.
Good morning, everybody, and thank you for the invite. It's always nice to go new places, especially after 2 years of sitting in offices giving these sort of presentations to blank screens. I apologise for my slightly more scruffy appearance, because although I'm here, my luggage is in Frankfurt. Hopefully before the end of this weekend, I'll look a bit smarter. So I've been asked to talk about circuit design. So when I started doing ECMO back in 2001, this is what you had on the left-hand side of the screen as you look at it, your big roller pumps. And I think you can't say you've done ECMO until you've played with these. They were, I think, awful. We then move on, and about 2006 started using centrifugal pumps. Now, the advantages of centrifugal pumps, you get assisted drainage, it makes transfer easier, you can use shorter circuits, they've got good biocompatibility. You've got to think about preload and afterload. With roller pumps, it's all about the preload, and they are very efficient. You don't need much power. About 30 watts will drive them, so you can do them in the back of the ambulance. On the other hand, roller pumps, you had miles of tubing, you had to have negative pressure regulators in the circuit, and they were a real nightmare to use. However, that might not be the case. This is a meta-analysis published recently looking at roller pumps versus centrifugal pumps, and whilst there's many problems with this paper, it might suggest that actually there are benefits in using roller pumps. I personally wouldn't. I hated them, and once we moved to centrifugal pumps, we're not using. I mean, one of the problems with all this data, it's from people's early experiences of roller pumps. I think we've learned a lot over the 15 years we've been using them, and I would suggest that that's the way forward. And you've got a lot of choice now. When we started, there was only one system, so you've got things like Centromag, CardioHelp, Xenia system, Eurosets now produce a pump, and if you've got lots of cash and you want to do adults or bigger patients, you've got a thing called Carl, which is made of carbon fibre and looks very swanky, but I'm not sure it's worth all the money. And again, things have developed from oxygenator point of view. You've now got a lot of choice, and pretty much any of the companies that are involved in the cardiothoracic field now have some oxygenator to choose. And again, they all work very well, they're all super efficient, and there's very little, at least in my experience, to choose between them. And often your choice depends on the size of the patient you're expecting to treat. For example, the Nautilus is a fantastic oxygenator if you're treating adults, but they don't do a small one for babies. The Paragon, maybe not the best blood handling oxygenator in the world, but it comes in 5 different sizes. So that's a plus. So he pays your money and takes your choice. But as I say, all of them work really well. There's a few overriding principles that I keep harping on about as circuit design. So I go all over the UK collecting children and adults for ECMO, and everywhere we go, they have enormously long circuits, unbelievably long circuits. And you say, why have you got a circuit that length? Oh, well, you see, when we come out of theatre or we go to catheter, there's that tricky corner we've got to get round, so we need the circuit. You don't need to do it like that. Get away from that idea. You want the blood path as short as possible. That gives you a reduced inflammatory response, so your patients prefer going onto ECMO. You get reduced resistance to blood flow. For example, on Wednesday last week, I collected a child, had an awfully long circuit. I chopped at least 1.2 meters out of the drainage side, 1.2 meters out of the arterial side, and for the same revs per minute, got 200 mils extra flow, just by reducing the resistance in the circuit. That makes you can come down on the RPM, you get even better blood handling, you get less hemolysis. And also, if we know ECMO patients bleed, so you need a lot of platelets, FFP, cryo. If you've got a short circuit, you get more bang for your bucks. So 1 unit of blood will raise your HB by more. 1 pool of platelets will raise your platelets by more. And then you've got to think about access. You say, I'm a great fan of putting the access onto the circuit. The nurses prefer it onto the patient, so we have a regular fight about that. Then there's pros and cons in both. But remember, especially the smaller patients, if you've got an ECMO circuit, use it. As you get more to adult life, or certainly big pediatric patients, IV access is often better on the patient. And think where that access is. If you've got a negative drainage side, pressure side, if you turn the 3-way tap the wrong way, you're going to fill your circuit full of air. The centre's tried all sorts of ways to get around that and say, oh, no, we have air maybe once every year. We've gotten rid of everything on the negative pressure side, and we haven't had an air incident in about 10 years. You get the odd micro bubble, but nothing catastrophic. Although I tell a lie, we had one recently when our chief perfusionist sat an adult patient up with the electric bed and forgot that the circuit was his restraining factor and pulled the cannula out. We got air in there, but we sorted that. The key to any successful ECMO run, whether it be VV, VA, whatever, it doesn't matter. It's about getting the right size cannulas in the right place for that patient. You don't need to go enormous. It's about having the right size. But there's certain brief bits of physics. So you've got to think that Purcell's law states that the flow through any tube is proportional to the fourth power of the radius times the pressure divided by the length. So in other words, short and fat is best. But you can't go too fat. So the top cannula, smaller, but may give you better overall performance because your total flow might be reduced, but you get much more consistent flow because you're bringing the side holes in the cannula into play. The bottom picture, that fantastic maximum flow, but every time the patient breathes, coughs, sneezes, turns in the bed, you lose it, or you end up having to give the patient loads of fluid to maintain that maximum flow, which then the patient gets very boggy, the lungs get wet, and you perpetuate your ECMO run. So it's about the right size. So big enough without being too big. Again, there's lots of manufacturers of cannulas, and each cannula is slightly different. What you want is one that works nicely. So you want it to have a big enough internal lumen to give you the flow, but not so that the wall's too thin that it keeps collapsing. So we're talking about VV today, so it's, I think, more straightforward, and the whole VV ECMO run is more straightforward than VA. And really, anybody with a bit of intensive care training can cannulate a child for VV. I've got now 7 colleagues in the adult side, and they're all happy to put people in VV. And actually, COVID was great because we managed to train 3 new intensivists to cannulate in a 6-month period where it would normally have taken a lot longer to that. However, there's lots of places still like your friendly neighborhood surgeon there because although complications are infrequent, if you do get one, it rapidly spirals out of control. You've already got a patient who's critically ill and you have to, you're in a situation where suddenly you've got a big bleeding problem or you've done something silly and stuck a cannula out through the bottom of the heart or these things. And generally patients going onto ECMO don't tolerate these sort of things very well. Imaging is good. I think it's now the gold standard that everybody uses ultrasound for most placements of any catheter into the vein, certainly the central veins. It is good for getting in initially. You can confirm your wires in the place, and you can also size the vessel. As a rule, you want to try and get a bit of flow past that cannula if you can, and I would certainly go to a maximum of 80% of the measured diameter on the vessel. And again, if you're going to go down the double lumen cannula route, which is certainly, I think, a good option in larger children, then fluoroscopy is the way forward. So how you do it depends exactly on what you do. Vessels used commonly are right internal jugular vein, right femoral vein, left femoral vein. People use the subclavians. You can use left internal jugular. You name it, you can use it. It's about being adaptive and not have a a predetermined, we're going to do this ECMO, we're going to use this vein and that vein. You've got to think sometimes outside the box. Few tips on how to do it. If you, for example, have got a bigger child, you're using the femoral veins, it's important where you hit. It's not just good enough merely to hit it. So you want to hit the vessel below the inguinal ligament. That has the advantage of it, if you inadvertently hit the artery, you're going to know about bleeding. If you hit it above the inguinal ligament, you go home, you have a nice meal, cup of coffee, everything's good, you're really pleased with yourself with the successful ECMO cannulation, and then usually about 2-3 days later the patient's abdomen blows up and you realize you've got a significant retroperitoneal bleed because that arterial puncture is just oozed and oozed and oozed. So go below the ligament. Other things is remember that the femoral vessels curve, so they go deep down in the pelvis. So if you leave any introducer you've got and leave it long, that helps you get around the curve. ECMO cannulas are fairly stiff and tend to go in a straight line. So anything that helps them follow that curve is good. And again, when you're getting your initial stab, try and get it at an acute angle rather than a lot of people with a central line will go straight down. A small central line turns corners very well. A larger ECMO cannula doesn't. One thing that's often overlooked is how you tie these cannulas in. Once you've spent the time getting them there, make sure they stay there. And there's various techniques. Again, it maybe not demonstrate very well, but I like a nice big bite through the skin and make sure they're tied in well. You don't want them too tight to the skin so that you get skin necrosis, because some ECMO runs are quite long. And if the skin starts breaking down, then the cannulas become mobile, you get infection, you get all sorts of problems. So a loose but secure tie is important. If you're going single lumen cannulas, bigger your patient, bigger the cannula you need, right up to sort of 100 kilo plus, which I know you do get. I think the largest ECMO patient ever in the world was done not so far from here. That was an adult in Qatar who weighed 510 kilos, which was quite impressive. We haven't gone that big. And then you've got the option of dual lumen cannulas, and I think these are very good if you invest the effort into getting them in. They can be a little bit tricky to insert, but you get very good flows. The first one of these on the market was the Avalon Elite. We've been using that since 2008, and you get very low recirculation. In sheep models, Joseph Zwischenberger, who designed it, found about 2% recirculation. That can compare up to about 50-60% recirculation in single lumen cannulas. And it comes in a wide range of sizes, from 13 French, which we've used in a 2.38 kilo baby, up to a 31 French, which we've used in a 237 kilo bloke. The advantage of double lumen cannulas: reduced risk of vascular injury. You've only got one cannula. Decreased infection, you avoid the groins, less blood vessel bleeding, increased sites of venous access off the patient, and increased venous access when you're off ECMO and doing well. It's good for reduced circuit length. If you're doing bigger children and you're single lumen, maybe say fem jug, you've got to have at least that amount of circuit to bridge that gap. With a double lumen cannula, they can both come off and you can get a much shorter circuit. It's easier getting your patients awake, which I think is becoming increasingly recognized as an advantage to ECMO. You can get your patient awake and mobilizing, and that is certainly safer with a dual lumen cannula. I'll come back to that in a second. Mobile ECMO is good. You can see the cannula. Proning's easier. You're not then lying on one of the cannulas, and it's very easy, just a single person looking after that cannula as you turn. And again, we prone a lot of our patients. It works equally as well on ECMO as it does off ECMO. And there's certainly increasing evidence to that. And again, it's easy enough to train anybody to do. So the other thing is reduced vascular injury. This is a patient we had who was cannulated by another centre, and then we took on the care, and you can see he got a big hematoma in the groin, which then got infected and turned really quite nasty. Most of them. As I say, with double lumens, you need fluoroscopy. You can, if you've got a really gifted cardiologist, and I know we've got a couple from Glenfield who are working in this area who will be able to help you with this thing, but fluoroscopy is great because there's a tendency for guide wires to do that. Now, if you're a cardiologist, you see the wire here and you see the wire there, because you're a cardiologist and used to thinking outside the box, you assume that it's going in a straight line, but it doesn't. And what happens is you push the ECMO cannula down here, it comes, and it can't really loop back on itself, so it goes out the bottom of the ventricle, and that gets messy. You do get good flows. This is across the range. If you insert an additional cannula, as we did, you don't often get additional flow, and that's because of this. So, as I said, if you're using a centrifugal pump, it's as much about the afterload. So the size of your return is equally as important. A roller pump will pump blood through anything, and it doesn't matter. It was all about the drainage. Big drainage, big drainage, big drainage. Centrifugal pumps, you've got to have the return, because the more resistance for the blood going back to the patient, the more that spinning disc in your pump slips, and the less efficient your pump is. So you've got to do it. This is our biggest patient, 237 kilos. We didn't accept him at that. He grew about 117 kilos from the point of referral to the point of coming here. Just nobody had actually put him on any scales. But again, he was supported for 3 weeks with COVID through a single cannula in his neck. About the mobility issue, again, this is about the limit of my research. I'm not a researchy type person. I'm a much more doey type person. So I said, well, what about mobilizing on ECMO? And we have mobilized kids. It's not just the domain of adults. Is stuck it into Google, and it produced all these pictures. I then went through and looked at those pictures, and the ones with the tick are the ones with a double lumen cannula. The ones with a query are the ones that you just can't tell, and the ones with a cross are the ones with a single lumen cannula. So you can see double lumen cannula from this limited research, not published, is that double lumen might have an advantage there. This is X-rays of double lumen cannulas. This one's too high, this one's too low, and this one's just about right. It's a bit like Goldilocks. So if you have the cannula high, you get a lot of recirculation because this jet just comes up to here. If it's low, the return just pushes blood down the way, and if it's just right, and especially if you're in sinus rhythm, you move the blood nicely around the body. If you're doing smaller patients, you have a choice of dual lumen cannulas as well. You've got two. This was the original Avalon cannula that we did about 78 children with, or babies, and we got about 5 perforations, and we're not sure why that was. This is delayed perforation between about 2 and 10 days into the ECMO run, which was a little bit scary at times. Fortunately, all those patients survived. This cannula here, the Crescent RA, produced by MC3, marketed by Medtronic, has just been out on the market for about a year. Released in the United States first, which is a change. It used to be we got them in Europe first, and people are finding it's working very well. It's designed, this one's designed to go bi-cable, so drains SVC, returns RA, and drains IVC. This one drains from SVC in upper atrium and returns into the mid-atrium. To get them in, I prefer, especially in smaller babies, to make a hole. Find the right bit, chop down, find your vein, and then put that in through a separate stab, so a little stab in the neck, put a needle down into the vein, upsize that to a bigger sheath, and then over a guide wire, just get and push your cannula in. Again, if you've got a cardiologist around, it's useful to have them putting pictures on the chest, and certainly in neonates, you can get some very nice pictures. They have much better echo windows than larger children and adults. And then once you've got the cannula in, connected up, and away you go. VV used to be, or was getting to be, the mode of choice for most neonates until we had the problems with the perforations in adults and these kids, and that Avalon cannula was removed from the market for a while. It is available again. So there was a switch to doing a lot of neonates VA because there wasn't an alternative. This is a reinvention of an original idea that was done by the sort of founding fathers of ECMO, is can you do to a neonate what you would do to a larger kid? So, hang on. So put a cannula in the jugular to drain. We know we can happily put 13 French, 12 French cannulas in neonates of around 3 kilos. But then rather than drain or return to the artery, return to the femoral vein. And this is done from a guy called John Lilly out of the Evelina in London. Small numbers of patients. I think he's done about 20 now, but fairly small. 2.1 kilos is quite good to get on VV ECMO in the neonatal population. Good flows, so more than 100 per kilo on average. However, this is where the sort of stumbling block and the big question mark lies, and what we don't know is all these children lost their femoral vein completely. And he's followed them up at least to a year, and there are no problems. Whether, as Bob Bartlett, the guy who, well, if without Bob we certainly wouldn't be here, I think it's fair to say, basically said they tried this early and it did cause problems as animal models grew, as the first children they tried. So, but it might be an alternative to think about. Again, people have tried in the past to cannulate the umbilical vessels in neonates. Haven't personally given that a go, but I think, again, that's coming back to the fore as a potential to avoid carotid artery sacrifice. However, having said all that, the ELSO data doesn't suggest that there's a big problem in tying off children's carotids, and actually most of the children who come through ECMO, even VA ECMO with standard neck cannulation, do very well. And that's bang on time. Any questions?
Thank you, Dr. Chris, for your lecture, and thank you for coming from UK direct to Abu Dhabi last night. So I'm adult ECMO person.
Yep.
I'm adult cardiac intensivist, so it's my opportunity to learn now more and more about pediatrics because, I'm on the steering committee of this project. So how long it takes for cannulating neonates and children as well for the dual lumen cannula or the double lumen, two cannulas, single lumen, two single cannulas, right? And what is your strategy?
So basically, the smaller the children, they're going to end up with VA. And I think at the minute, that's where we're at. We can't get hold of the mid-atrial cannula, and with our past experience, we're a little bit wary of the dual lumen cannula in the neonates. We still use it, but usually I would wait till they're about 4 kilos. So a big meconium will get a 13 French dual lumen. Down to about 3 kilos, it'll be VA. Once you get out that neonatal period, we'll start using dual lumen cannulation as our first line. In terms of time, how long does it take? We would look to, with a lot of our children are mobile ECMO, and we set a target of being from leaving the ambulance to being back in the ambulance within 2 hours. And that is an achievable goal. I think the quickest we've done, not that it's all about speed, was about 1 hour and 15 minutes. And I think the longest is about 7-8 hours, something like that. But that was everything that could possibly go wrong, did go wrong. But yeah, even to sort of take a patient, either do it at the bedside with echo, if you trust your cardiologist, or go around to theatre, cath lab environment to do that, it shouldn't take too long. And again, it's about the same time frame as two single lumen to dual lumen cannulation. In the bigger kids and adults, if they genuinely couldn't be moved, if they were, say, on an oscillator, very unstable, we would tend just to go for a single lumen approach at the bedside. But I think the effort you invest in the dual lumen cannula pays dividends throughout the run. Again, we're slightly unique in the UK. The only centre doing dual lumen is a first line, but that's because I think the history of the unit. We were sort of a surgical unit and then invited adult intensivists into the programme, and they just adapted very early to this idea of dual lumen cannulation. And actually, we've gone a good number of years without any major problems. But they're all trained to do a single lumen approach for those patients who can't get to theatre.
Thank you very much for a great presentation. How do you go about the privileges for putting this cannula by anybody, you said, intensivists who are trained to do it? How much of training and how anybody can claim I can do it? Is it okay?
No. We start out with a sort of very close guidance. So all the people we're training are sort of consultant level intensivists, done many standard triple lumen, quad lumen lines. So actually the technique of getting into the vessel is what we're usually fairly happy with. With the dual lumen cannulas, there's a few tricks just that they need to learn about getting the guide wire down into the IVC. There's a few sort of little things I've picked up from spending many hours watching cardiologists and supporting babies on ECMO standby and how they manipulate wires. So we teach that, and on average, I would say it takes about 10 cannulations for your average intensivist to go from complete newbie to being happy to go out. Some have taken longer, some take even less. I think we had one guy who was happy after about 8 cannulas. Again, it depends what happens. If you've got a cannula that just drops in as easy as you like, you don't learn anything. It's having that ability to get yourself out of a sticky situation that you need to develop.
Do you use simulation for training?
Not really, because I think it's certainly for the smaller centres it's a must. But I think we're in the lucky situation of doing over 100 ECMO runs a year. We have enough in terms of patient population to train and maintain skills. And I think it's also, we've tried to keep it to a smallish group. I mean, I say that, 8 intensivists or 7 plus me doing the adults might seem a lot. But when you think there are about 24 intensivists now, so it's about a third of the pool that are doing it and do it regularly.
Just one quick final question, Chris, about carotid artery ligation and reconstruction, because I know you try to reconstruct as many as you can. Do you have an idea of what kind of patency rates are achieved, not necessarily by yourself, but by worldwide?
I don't think it's great. I think those who've looked at it, it's around about the 50% mark. Again, it depends at what stage you do it. If you look at it immediately after, they're all patent, but the further you get out. But I certainly, first line would be to try and reconstruct, but if there's any doubt or I just don't like the reconstruction afterwards, I just tie it off. And I think that's by far the safest and best way.
Good morning, everybody. I'm Adeeb Khawaji. Thank you for having me here. I have a chance to wake up and take care of myself, Chris. So it was a very nice lecture and interesting always to hear surgeons when they start to speak, because the language will be clear for the practical part of ECMO. So thank you for your lecture. And thank you for the organizing committee for inviting us here. I have been selected to speak about gas exchange. So unfortunately, I have to go to basic of physiology, then I have to move to the other part. So almost half of my presentation will be in physiology to know the mechanism of gas exchange. I'm going to pay attention mainly to the physiology, then we're going to speak about oxygenation, CO2 clearance, and then ventilation. I have no relevant disclosures. So this simple picture can be reviewed by any pediatrician or pediatric intensivist when reviewing the cardiopulmonary physiology. Simply to speak about, I'm not sure if it's about the oxygen venous difference in the oxygen content. As all of you know, that the oxygenation component of our system will be saturated with 100%. And as long as you're moving to the tissue, you have oxygen consumption here with sepsis, with work, with exercise. And this oxygen consumption will end by CO2 production. And then it go back to your venous part where you have your ventilation. So in simple language, the oxygen gets into the blood via perfusion of the capillaries. And regularly, we have 5 times more oxygenation in our blood than we need for our metabolism. So the common equation for us, which is about the arterial oxygen content, depends mainly on the hemoglobin oxygen saturation. And the CO2 production after the oxygen consumption is around 3 cc per kg per minute. Here you can see a very clear role of hemoglobin. Very clear role of hemoglobin during the process of oxygenation. So the arterial oxygen content here will depend mainly on the hemoglobin level. So if you have a normal hemoglobin level, your arterial oxygen content can reach up to 20. The more you lose in your hemoglobin, the less arterial oxygen content saturation. For oxygen delivery, we have factor of the arterial oxygen content and the cardiac output, which is a major determinant of your oxygen delivery. So if we move to the oxygen consumption, the normal metabolism for adult population around 3 cc per kg per minute. Yes, that will be better. So the normal oxygen content for our adult population is around 3 cc per kg per minute, while in the infant we have around 5 cc per kg per minute. So our consumption for adult population around 120 cc per minute per meter square. So if we go back to the oxygen kinetic and what's going on there in our oxygen kinetic, in a simple way, our oxygen saturation will be after finishing our ventilation at lung level and going to systemic circulation around 100%. We are using almost 5 times of our need when we oxygenate our arterial oxygenation. So we're going to use 20% in the process of metabolism, and then our 80% of oxygenated blood will go to the veins and return to the heart. This is in the normal physiology. As I mentioned earlier, so we have 5 times of our oxygenation. And we are in a safe place if we increase our metabolism for any reason, for the sake of sepsis, for the sake of shock, till we reach to 2-wise ratio between the oxygen delivery and the oxygen consumption. Once you reach to this zone, your care is going to switch back to use anaerobic metabolism. And there we move to the area of lactic acidosis, the area of shock. And if we as intensivists, we should think about this stage before it arrives. So we can bridge here always for our intervention. So the area selection of your patient, it depends on the calculation of your oxygen consumption and oxygen delivery. The area chance, if you catch your patient here, even better for referral. But if we wait here, I don't think so. If you don't have mobile ECMO unit, you can arrive safely to the safe place. So the skills about choosing patient, it depends on the understanding the physiology of this population. So, simple physiology about the normal venous oxygen saturation, because our talk will be about DV ECMO. The PO2 will be 40, saturation 80%, and the oxygen content around 60 per deciliter. Consumption, as I mentioned earlier, includes with exercise and sepsis. And we are, in terms of our delivery, limited by our cardiac output. We'll speak about later when we move to the area of DV ECMO. So, what's happening in DV ECMO? Simply, we are taking a blood from a vein, deoxygenated blood, and we move it to the area to be oxygenated through our oxygenator. So we should be very careful in this area because we depend mainly on the cardiac output. Our heart should work very well. It's totally different from the ECMO where you have artificial heart to support you. So once you reach to this area, you should be sure that you have your hemodynamic support to the patient, because simply we are not supporting the patient with ECMO. We're just doing the oxygenation via artificial lung. So daily ECMO does not provide patient with direct hemodynamics, purely with your network with support to optimize your cardiac output. Complication very common with daily ECMO is our recirculation, and it affects really our oxygenation. I used to say to my colleagues always, as intensivists, we love the magic number of oxygen saturation of 100%, above 90 to the side, which is totally different story on DV ECMO, where you have, you can live regularly as you maintain hemodynamic in 80%, because your circulation will be compromised by your venous flow if you have some work in your lung there. So, as you can see in the DV ECMO, you have replacing both the lung and heart, but DV ECMO, you are just replacing the lung job. We should be very careful about this terminology, especially when you are dealing with non-expert in ECMO prior to transfer. Be aware about your calculation always on ECMO after the oxygenator and pre-oxygenator. You have to calculate always your oxygen delivery and oxygen consumption to be sure that you are managing your ventilator very nicely. Also be always aware about the monitoring of hemodynamics, because you are not getting support of your hemodynamics. Just to make it simple about the oxygen delivery. I make this slide just to make it short for the oxygen delivery. I know that it's a little complicated with a lot of equations, so I just make it easy to the points. So your oxygen delivery will depend on the blood oxygenation in the membrane lung, which work as a main part. The more oxygenation you get after the exit, the better for you. Flow through the circuit, because the effect, as mentioned, by the diameter of the your pump, which can help you a lot, the diameter of your oxygenation and the flow. And then it depends on the job of the native heart and the native lung to support the oxygenation. So arterial oxygenation from 60 to 90% will be in DV ECMO. And this will depend mainly, as I mentioned, on the ECMO flow, the native venous flow, lung function, and the cardiac output. This relation often conflicts with IC-star, because we don't like to see these numbers. Always our target always to have a good numbers, but you should be aware that as long as you are maintaining hemodynamics, you can accept as low as 70s with stable hemodynamics. So in our gas exchange, we should know that the oxygenation supply from membrane lung is dependent on the blood flow, the hemoglobin concentration, and the difference between the outlet minus the inlet content. Because the outlet blood is 100% saturated and oxygen PO2 more than 500, dissolved oxygen as much as 10% only. And even if dissolved PO2 is more than 400, only 1.2 oxygen per 100 ml blood is added to your oxygen content. So, what is the amount of cardiac output for your population in DV ECMO? Depends on two things: the ECMO flow and the native venous flow. So, the flow of the vein, which passes through the RV, the flow of the veins here, was going to the RV through this part, not related to the ECMO, is the native lung flow. And this can affect your saturation, because if your lung is safe, you get most of the time, you get a couple number of oxygenation there. So you'll not have too much increase in the oxygenation and it will affect the ECMO flow. So don't worry about saturation, and it's not mean that the saturation of the ECMO. It has saturation of the ECMO and saturation of the native venous flow. Here is just a quick picture of our oxygenator part. So when the blood go through this oxygenator and go out, it passes by many hollow fibers, thousands of hollow fibers inside the oxygenator. And this fiber is made of substance, very nice substance that allow the gas to flow to the blood, but not the opposite. So the faster you have the blood through this circuit, actually it depends on the size of the oxygenator. You have many sizes, as mentioned earlier. And the faster the flow you get, is better. But at a certain limit, the faster flow you get is this saturated blood. So you should be always about the velocity of the blood. And all of these factors can affect your oxygenation. Here what I mentioned earlier about a certain flow, you have 100% at outlet of your membrane oxygenated. But with time you get more faster of the flow, you start to have a decrease on the saturated blood. And that's what we're going to speak about, the term of rated flow. So combination of venous access cannula, membrane lung size, and hemoglobin concentration should be planned to match the exceeding resting oxygen consumption. So moving to this important part, when I said to my people always, our lung, membrane lung always function at normal hematocrit. And if you have choices to affect your oxygenation, I'm always going in favor of transfusion rather than adding another excess of penicillin for our population. I don't have to have another way, we'll see after the issue. So for CO2 clearance, simply you can manage it with managing of your sweet gas, and you don't need to have a higher hemoglobin like oxygenation. And the actual amount of CO2 removed by the membrane is equal to the inlet of CO2 content minus outlet multiplied by flow. So, as I mentioned earlier, in axis parameters should be monitored always, and that should adjust your ECMO to maintain VO2 and VO2 3 to 1. Do not wait till you arrive to 1. This is the factor that affects your oxygenation, as we mentioned earlier. And I'm going to move to the area of ventilation with the ECMO. So in ventilation, we are always focused on terminology of lung rest strategy, where we have low ventilator rate, moderate peak, and low peak inspiratory pressure. We finish the procedure so I can go back and speak. So when you speak about the ventilation in VV ECMO, our goal should be always lung rest via reduction of polytrauma and volutrauma and minimizing the oxygen toxicity. The typical rest, where you have low or normal PEEP less than 25, if I2 less than 50%, with low respiratory rate, and PEEP between 5 to 15. Use of lung recruitment is still controversial. I prefer not to use it. And spontaneous breathing should be always allowed to enhance our lung recovery and lung rehabilitation. If pneumothorax develop, the ventilator setting can be further reduced. INO can be used to treat severe pulmonary hypertension. Suggested setting to start lung protective strategy on mechanical ventilator doing VV ECMO. And I just went over this study, which is very interesting for me. So they studied the population here from 2011 till 2016 to see the effect of the mechanical ventilation and veno-venous ECMO. And through this study, they found that the only ventilator setting associated with mortality was high FiO2. Further review through this study of rest ventilator by Matthew and his colleagues, and they found they studied a very nice number of around 1,161, And they found in their survey around the median setting for rest setting of ventilation with the rate of 12, peak inspiratory pressure of 22, positive PEEP of 10, and FI2 around 0.4. And also they found higher ventilator FI2 was associated with mortality. So for VV ECMO, use protective ventilation with low tidal volume, high PEEP, and prone positioning. There is no contraindication for prone positioning. In summary, to take home message about ventilation in VV ECMO, protect your lung during the ECMO, allow the patient to breathe spontaneously if they can tolerate it and not affecting your flow. No recruitment by maneuver at all. Minimize the plateau pressure, target tidal volume is 6 ml per kg. Manage your PEEP to mitigate the atelectasis and decrease the respiratory rate. Prevent excessive swings in transpulmonary pressure. That's all of my talk, and those are my references. And happy National Day for their colleague in Emirates.
Any questions for Dr. Adeeb? No?
You said there about targeting 6 mils per kilo, but what would you do in the patient who you can only get 0.1 mils per kilo or 0.5 mils per kilo?
So if you speak about 0.5 and 1 ml per kg, I always ask my surgeon when I have small neonates or infants to use the central ECMO rather than peripheral ECMO to achieve my flow.
No, I was meaning in terms of tidal volumes, you know, so... If
it's not doable, it's not doable. You just give it time for lung to recover. And this, actually, to be honest with you, I went over a lot of studies. I just summarized my talk from 70 slide till 40 slide last night. I spoke with Duthie that I'm trying to adjust it. I went through a lot of articles and a lot of reviews. A lot of factors has been affecting directly on the mortality of this population with different studies. Some of them speak about the main airway pressure, the plateau pressure. And once you have more sick lung, you expect longer time of duration of ECMO. And when you speak, like, here is the deal of the rate. I don't want to confuse the people, but here is the deal of the rate. Always we allow, we advise the people at the start to paralyze the patient and keep him with no breathing to optimize your ECMO circuit. And think about simultaneous breathing only when you have a long bridge to the transplant, lung transplant. When you have such lung with 2 weeks of ECMO, 3 weeks of ECMO with no recovery, we can wait up to 6 weeks in VV ECMO. We should think about lung transplant or the alternative plan for this patient. And those time we just bridge our patient to tolerate low tidal volume, thinking about next fund. At the same time, maybe we're gonna have chance for some lungs to recover. But again, I'm not in favor of lung recruitment maneuvers.
Any other questions down this end? Oh.
What make you, Dr. Adeeb, shy away from recruitment maneuvers? The idea that you're resting the lung in VV ECMO and the lung is going to collapse. If you want to wait for it to recover spontaneously after being on low setting, it might take a long time. Anybody have compared those two strategies, recruitment without recruitment?
Again, interested talk. The articles are really controversial about the recruitment. Interesting for me, I went over, I believe, Japanese or Chinese study, and they use the high frequency, more frequent during VV ECMO, and they have a better lung recruitment than conventional ventilation. So I would go for high frequency if I needed to recruit the lung rather than using recruitment maneuver and affecting my patient. The evidence is not supporting at any chance using of VV ECMO so far.
So it is the technique of recruitment, not really having recruitment or not having recruitment.
Yeah, well.
So you can still do recruitment, but different maneuver than just the bagging, the high pressure or picking the pressure.
To speak it in a physiology language, the people when they speak about the recruitment, they used to push their PEEP to 20 and 20, or sometimes they would adjust the ventilator to do it every 6 hours. This is not the best way of recruitment for sick lung, because as far as increasing this shearing forces to the lung, don't expect a better recovery. So the basic idea of VV ECMO to rest your lung, keeping optimally distended with an optimal PEEP. This PEEP can go 15 if you need, and 10, and around some studies they did up to 20. But the higher time of this high PEEP will reflect it back on the 28 days survival, as per studies that I have been reviewed. But yes, I can use my PEEP also to optimize with better PEEP. I don't mean recruitment, I mean the manual technique. There is people who, when they recruit with the PEEP of 15 for 2 minutes or 50 seconds, and then they leave it. This will not help the lung to rest. Actually, it gets lung more sick, and this will gonna lose the advantage of VV ECMO. I'm not sure about our adult colleague, what they are doing in recruitment. They love it or they don't love it, Salman? Yeah. And actually, our evidence always taken from your adult population. Most of the studies, not pediatric one.
Well, we take, knowledge from pediatrics and, the same thing probably. We are not toward doing recruitment maneuvers anymore. So if the patient is reaching to the maximum acceptable PEEP, which is 12, 14. So before, I think people were liberal with the PEEP strategy. And we have seen more harm to the patients in the form of barotrauma. And we learn more, in the COVID-19 ERDS. Yeah. So we accept PEEP of 10 to 12, and probably obese patients, we go more with the PEEP. But beyond that, no anymore. We don't increase the PEEP more than this. And we just think about ECMO if the criteria are fitting to the patients. That's it.
In pediatric, because we love a non-ECMO patient to have recruitment in some population. And I think the people still have believed it, but so far there is no support for evidence to use a regular manual recruitment. You can use the optimal PEEP to achieve your tidal volume around 6 ml per kg so far.
Thank you. Just one comment before we finish with the high frequency that you mentioned in the paper, Japanese or Chinese paper. Our adult colleagues have shown conclusively that high frequency is not good for lung injury in adults. So high frequency is off the agenda for adults, but I share your practice in that I still think there's a place for it in pediatrics. Okay, we'll get underway now with the next group of lectures. So I'm going to be talking about management strategies during neonatal and pediatric VV runs. For those of you that don't know me, I've been here at Sheikh Khalifa for the last 7 years, and prior to that, I was 10 years with Chris in Leicester for my sins. He taught me enough there to have helped me out in my adventure as the ECMO lead now in SKMC. So let's get underway. So we're going to look at key points when we're initiating VV support, understand some options around poor hemodynamics in these patients, look at what we do when we encounter hypoxia despite ECMO support, and I'll describe some of the techniques we use to help lung recovery in these patients. So, as we heard in the physiology lecture by Dr. Adeeb, we are putting patients on ECMO, and the oxygenator and the circuit are in series with the patient's circulation. So we require adequate circulatory function from the patient in order to do effective ECMO, to deliver oxygen to the tissues. ECMO flow requirements vary with age. And at the lower end of the scale, with neonates, we may need up to 140 mils per kilo per minute of ECMO flow to deliver adequate oxygen. Whereas in older children and up to teenagers, it's much lower. The requirement can go down to as little as 80, which is a figure more used to, adult ECMologists would be more used to. We also have to remember that the oxygenator that we're using has a capacity constraint, as well as the cannulae. And it's not just, as Chris highlighted earlier, it's not just the access cannula. We need to remember that the return cannula resistance is important in our calculations. Here's a useful app, and this one is available for Android. It was previously that the only decent ECMO calculator was on Apple, but this one's available for Android. It's done by a perfusionist chief perfusionist from somewhere in India. I don't know if our team know him, but yeah. So this is very useful, and it's got a nice calculator, not just for cannula size, but other useful things like Murray score and recirculation factor, and we're going to be talking a bit about recirculation later. So when we are initiating a run, and we've got the cannulas are in, and we connect it to the circuit, and we're just starting out, we have to remember that this patient has been experiencing both hypoxia and hypercapnia. And the physiology of the patient will need to adapt now to you introducing oxygen into the system. And the key is to do this gradually. There are some circumstances where the patient is crashing and you don't have the alternative of doing it gradually. But by and large, with VV runs, you have got time to gradually increase the flow. And this is important because you want to avoid clearing the CO2 down too low, hypocapnia, which can damage the brain, or hyperoxia, which is also, there's increasing evidence to show, is deleterious for our patients. So we go slowly and gradually increasing the flow with the sweep gas initially set at the same amount as the flow. And then we titrate the sweep gas flow depending on the patient's arterial blood gas, and they need to be done fairly frequently early on in the run to make sure that, once again, that we're not going into hypocapnia or hyperoxia. And the targets, saturations that we're aiming to achieve, around about 85 is plenty for these patients with a decent hemoglobin, and that's an important caveat because oxygen delivery depends on adequate hemoglobin if you're running SATs of 85. This picture gets shown a lot. It's impressive. It's a neonate, well, it's not, it's an infant, isn't it? Who's wide awake, looking intently at the person taking the photograph. It's rare to achieve that in my experience in this age group, but anyway. So, adequacy of oxygenation. We have to plan out our circuit and our cannula size because we want to avoid having to ventilate the child after going on ECMO. That's the main reason for going on, is so we can rest the lungs completely. If we fail with our calculations or our flow is inadequate, we end up having to ventilate the patient and defeats the object of the exercise. So we monitor how well we're doing in terms of oxygen delivery with NIRS, near infrared spectroscopy. And in smaller children, we place one probe on the head and one on the kidney to compare systemic and cerebral perfusion. I've mentioned about hemoglobin before, and as we heard with Dr. Adeeb, we should try to aim for oxygen delivery more than 3 times the baby's consumption. But if we are in a difficult spot, we can consider reducing oxygen consumption in the patient by muscle relaxation or even cooling. But by and large, you don't want to cool because of the effects on both on hemostasis and on immune defense. We talked a bit about circuit configuration with Chris, and double lumens below 3.5 kilos are a little bit challenging. I think there's a group in Italy that have managed to get down a bit lower, 3 kilos. But we generally wouldn't do that. So then 2 and 3 site VV circuits are usable, but then they're also in larger children. If we are going to do two-site cannulation, femoral access and jugular return is a preferred configuration because of that way round you avoid recirculation. And you have to remember to keep the tips of the cannulae adequately separated. They say 10 centimeter separation is the standard for adults. It can be a little less for children. Femoral access is not used under 15 kilos. Well, we heard about the group in guys who've done it, but at the payoff of sacrificing femoral veins. So it can be done, but at a price. So well-planned initial configuration is important. And then if you're in a difficult spot and you need to make a new plan, you have to avoid getting into oxygen debt, which Dr. Adeeb mentioned, because of the consequences on organ failure, and it just makes the whole thing more messy when you're trying to alter a circuit with a child that's collapsing. So here's the two-site comparing the jugular access and femoral return with femoral access and jugular return, and this is the preferred option because of the recirculation is much less with the option on the right. So coming now to hemodynamics, and this is quite a difficult part of the clinical practice. As people gain experience with VV ECMO, you will see that they put people on VV even on significant amounts of inotropes, because although there is no direct support for the circulation, improving myocardial oxygenation and pulmonary vascular bed vasodilatation are very useful ways of improving the baby's hemodynamics. And I think the last case that we put on VV, an 8-kilo child with RSV pneumonitis was on 0.3 and 0.3 of epi and norepi and came off nicely within the first hour or so of the run. So if, however, you put somebody on VV and then the right ventricle starts to deteriorate, what are your options? Or if in the beginning there is a difficult choice and it's not so obvious which way you want to go in terms of the choice of VV or VA support, you need to be ready, you need to be prepared. And you can prepare in advance a VA access, an arterial access. You can put a wire in an artery and you can be ready, and your perfusionist is standing by to adapt your circuit. So then you can either go straight from VV to VA, or there are other options. If you do go from VV to VA, it's a small number of children in the ELSA database, but there is morbidity and mortality associated with it. And of the runs in the database, only 45% of them survive to discharge. So somewhere in between VA and VV is this hybrid option where you access a vein and you return blood to both an artery and to a vein. And we'll talk about this tomorrow in relation to peripheral VA runs as a solution for what's called north-south phenomenon, when you get a baby with differential hypoxia. But it can also be used in this situation where you con VV and you start to have hemodynamic decompensation. So in the practicalities of handling a hybrid circuit like that, you have to be careful about how much flow goes down the second limb of the circuit. Either you choose a cannula size which is going to limit the flow, or you put a gate clamp on it. This is a series published, the only pediatric series published to date of hybrid circuit use, came out of the University of Michigan a long time ago, 2000 to 2014. Small numbers, but reasonable success. Now let's talk a bit about recirculation. It's an important part of managing patients on VV and should be something that you check with each shift at least, every shift for every patient on VV support. So you can use that calculator on the app that I showed you, but the formula that they use is here, and there's a worked example on the left, but essentially the clinical features of a patient with recirculation are that you will see the oxygenator blood becoming less, there's less color change, but it's bright. So both blood going into the oxy and coming out is very similar in color. So you have loss of color change, but bright blood. And the patient's saturations are falling at the same time. So that's the clinical hallmark of this problem. And the important causes for this are cannula malposition, where you've got them too close to each other, if you're using a two-site option, or as Chris demonstrated, if you've got your dual lumen either too high or too low. So cannula malposition. And then other things that can increase it are if you've got your pump flow rate or your ECMO flow rate is high in comparison to the patient's native circulation. So you might think that the solution for this would be to increase the ECMO flow, but in fact it's the opposite. If you've got high recirculation, you need to turn your ECMO flow down and try and improve the patient's circulation. And other important things to think about are what's happening in the right atrium, because that's where we are focused a lot of our access on. If that's inadequate because of tamponade from some injury to the right atrium, you're going to get progressive problems, not only with flow, but also with increasing recirculation. So thinking about it systematically, you can start off by giving the patient a volume challenge to see if that helps improve your color change on the patient. We can manipulate the cannulas, and actually probably before we do that, you reposition the patient, and certainly with a dual lumen cannula in the neck, that's one of the first things that you would try. Just extending the patient's neck, and specialists who've run patients on this get very adept at moving the patient around to try and improve the recirculation. You can optimize sedation, you can even introduce muscle relaxant, and as I explained earlier, you can try reducing the ECMO flow and increasing inotropes. So if all of that doesn't help, we go on to the next set of solutions, and we start off by imaging the patient, re-X-ray to check cannula position, look at the echo, exclude tamponade, etc. And if we are needing to reposition, then it may be better to do that in an environment where we can keep things under control, either in IR interventional suite or in OR or in a cath lab. And reconfiguration of circuits. It's not something that should be taken lightly, the decision to go to a hybrid circuit or change from VV to VA, so you'll need support of the wider team before you embark on that. It's an important thing to get as many people involved as you can at that point. Cannula migration, this can be a problem for patients, especially if they're awake on ECMO. But also, just in the early phases, when you've got a big inflammatory response going on and the baby swells up like a balloon, the cannula, even if it's well anchored at the skin, will migrate. If it's not well anchored, well, we know what happens then. It doesn't take much, just cares or even a cough, and the cannula can be displaced. But because I was trained by Chris how to fix cannulas, it never happens in my patients.
I come with a 2-week guarantee. After 2 weeks.
Right. Seriously, you would consider resuturing after 2 weeks?
No, just after 2 weeks, I'm happy to hang the babies from
Oh, right.
up until after 2 weeks, that's when they become a bit more bad.
Okay, okay. So we every day as part of the circuit check, the specialist will look at the cannula position and see where it is in relation to a mark on the cannula or the suture points. Of course, even if you're doing that and the baby is swelling up, you're not always going to detect a migration. So you need chest x-rays regularly. And the other clinical hallmarks we've been talking about, recirculation and sometimes negative access pressures. This is just a paper which actually we had an experience of repositioning a double lumen cannula with IR by putting a loop around the bottom end of the cannula. We were able to flip it back into the IVC. That was an adult patient. So you don't always, you can sometimes do things with IR when you've got a double lumen out of position. So now we'll talk a bit about lung recovery, the object of ECMO, and it's the ultimate in providing lung rest for our patients. As we often see early on in the run, the patient's lung might get worse as ECMO lung, we call it, and that's exposure to the circuit with the inflammatory response that generates. And it's not unusual to see the lung completely white out on VV runs in the first day or two. This is where we have to be patient. This is where the tidal volumes are not going to be any good. And we don't rack up the ventilator pressures because the purpose of the whole thing is to rest the lung. I'm not going to go too much into ventilator settings because we discussed that earlier on. But there is a role in severe lung leak for disconnecting the ventilator completely, as we've had to do on a couple of occasions recently with people with bronchopleural fistulae. So we're also going to talk a bit about extubated and awake in other sessions, so I'm going to move on from that one. We mustn't forget that the general intensive care of the patient is vital for lung recovery. It's not just put them on ECMO and forget about everything else. Every aspect of the patient's care needs to be top level. I know we're all proud intensivists, or most of us in the room, but patients on ECMO deserve the extra mile in terms of attention. Specifically looking at lung therapies and bronchoscopy, bronchoscopy in particular, useful for our patients. I'm going to look at a paper on that, 2 papers on that in a minute. Prone positioning, the evidence is coming in adults. There's 2 randomized controlled trials in proning on ECMO underway at the moment, but off ECMO, as we've already heard, there is good evidence to show in adults that it works in ARDS, and experientially for children as well, I would say it's a useful tool. Recruitment maneuvers we've discussed already. Steroids and ARDS protocols, they have their place. Tracheostomy is not something we do very often in pediatric practice, but certainly has a role. Awake on ECMO we mentioned. Other ancillary treatments. Surfactant is useful, particularly in meconium aspiration. It can help lung recovery. Perfluorocarbon is something that you may not have come across, but the diaphragms, we have used it in diaphragms. I'll show you some data on that in a minute. And then immunomodulators. Well, what do I mean by that? Azithromycin at low dose is often used by pulmonologists to help their cystic fibrosis patients because there's evidence to show that it slows lung injury in that group. It not only slows lung injury, it actually promotes lung recovery between infection bouts in cystics. And that, based on that, I use it in our patients on ECMO. Bronchoscopy. So I'm going to skip over that. Here's a paper, recent paper, showing experience in 204 subjects on ECMO. They could show lung volumes improved and dynamic compliance improved, and there was a low incidence of complications, but they couldn't, from this sample size, show any effect on survival. This is one of my favorite pictures. It comes from a paper by Fortenberry and his group. Look at those casts. It's almost like having an entire bronchial tree, isn't it? That's from plastic bronchitis patients. But once again, there's a big experience with no complications. Proning on ECMO, I mentioned already. This is an adult paper, a recent review. And essentially, I liked it because these nice EIT, impedance tomography pictures on the bottom. Oh. Show the benefit of proning and redistribution of the ventilated portions of the lung. So you can see the posterior ventilation in the pre-proning is 38, and it comes up to 50 with proning. These ventilators that show you real-time tomography pictures, I really want to get hold of them, but I haven't actually yet been able to. I don't know if anybody in here has any experience of using them, but they're the future. That's real-time feedback on how well you're ventilating your patient. Proning is a team event, and as we're going to practice later on, it requires simulation and preparation to do safely, but it can be done safely, and it needs to be done for at least 16 hours to have some benefit. So this is a picture of perfluorocarbon in a patient who's got congenital diaphragmatic hernia. The group in Michigan showed that they could grow lungs faster using this very dense liquid. But in fact, the outcomes weren't improved because although the lungs improved in size, the vascular remodeling, the blood vessels that went along with these newly grown lungs were still diseased, so the outcomes remained poor. What do we do if we don't see recovery in our ultimate lung rest tool patients? If they've been on for a couple of weeks and they're still, their x-rays looking really dreadful and their lung compliance is bad, well, even before 2 weeks, you need to start to think about what else might be going on, something else that you've missed, a hidden diagnosis, some underlying systemic illness perhaps. Or in neonates, in the neonatal group, there are some difficult disorders which turn out to be behind a poor recovery on ECMO, surfactant deficiencies, alveolar capillary dysplasia. And you can get more information by doing a high-resolution CT, and very rarely we have to biopsy children. I think Chris has done a few in his time, but we try and avoid it because of the bleeding complications. So how do we assess a lung recovery? Serial x-rays, tidal volumes and lung compliance, and eventually reducing support requirements. And when we're getting towards the end of a run, I think Dr. Nada will be talking about this later, so I'm not going to cover it in detail. We can do oxygen challenge. So in summary, when we're initiating, we need to go carefully. We need to plan it properly so that we don't end up having to reconfigure the circuit. Mobile, we're going to cover later. We can target SATs of 85%, but we need adequate hemoglobins to do that safely. For recirculation, we need to monitor it closely and do the basics, and that takes care of recirculation in the majority of patients. For lung recovery, rest settings, proning, bronchoscopy, steroids, and patience are the important things. And that's really what I wanted to say. So, any questions?
Okay. So again, I'm an adult intensivist. I want to learn from pediatric intensivist. All right. So we have prolonged ECMO in adults. Okay. What about the pediatrics? I want to learn from you. And what are the options of exit strategies for prolonged ECMO program, or even this is for the VV? Probably tomorrow we can talk about the adult VA.
So proning, the first question you mentioned. The good thing about proning in children is it's easier to accomplish because children are smaller. So on a practical level, it's not, you don't need quite so many people. Obviously you need the same care and preparation. And we have done it certainly on the patients that we've had here in SKMC. We've done it regularly in the longer runs with good effect. So I'm an advocate of proning, not just in adults, but in children as well. So that's the first part of the question. The second part, awake on ECMO in children is achieved, and I showed you my neonate at the beginning. With the smaller children, it's more difficult. Obviously, it's harder for them to be in an environment which is so threatening. So with older children and longer runs, it becomes more feasible. And in the time that I've been here, in the last 3 years, we've achieved it once in an older child who was on for nearly 6 weeks altogether. And she was awake and cooperating with her exercise regime. She had a 2-site cannulation. She had a lot of problems with myositis in her legs, and we were getting her to cooperate before we decannulated. And certainly the evidence for children who are being bridged to lung transplant, they're quite often the longest runs in the literature. I'll talk about them on the last day. Yes, there's good experience, growing experience with having them awake and exercising and even mobilizing. With once again, as Chris emphasized earlier, with a double lumen, it makes it a lot easier to do that. Any other questions? Okay. So next up, I have the pleasure of introducing Dr. Naga. Dr. Naga is our division chief in the cardiac ICU in SKMC, but has also spent some time in Melbourne in the past, and before he came to us here a couple of years ago, he was in Alderhay Children's Hospital as a consultant there. Thank you. So, my pleasure to introduce Dr. Naga.
Oh, thank you, Mark. Good morning, everyone. I hope you're enjoying the session, and I'm glad this talk is after the coffee break, because I spent most of my night driving last night on the National Day after taking my kids to the Lion King show. The show was great, but it was a daft idea to go on the National Day. So I have a tricky task of simplifying the complex topic of anticoagulation in ECMO over the next half an hour or so. I wish I had shares in anti-10A and antithrombin 3 vials, and I'm hope to secure some shares in the bivalirudin in the, I can't even pronounce it, in the near future. So over the next half an hour, we'll talk about why we should anticoagulate, the challenges of anticoagulation, how we do it, how we monitor it, look at the role of antithrombin 3, what we do at SKMC, how to manage bleeding, and look at heparin alternatives, future directions, and a bit about World Cup football as well. So globally, over 150,000 ECMO runs have been registered with the ELSO until October 2021. Wow, that's a lot of ECMO experience, but really we still struggle with anticoagulation. Surely someone should have cracked it by now, right? However, the optimal anticoagulation is still a challenge, and it remains a conundrum. Why is that? So, bleeding and thrombotic complications are the most frequent causes of death and morbidity in ECMO. And bleeding and thrombosis has reported to be found in 40 to 70% and 30 to 45% of ECMO patients. Of course, they will bleed because you're going to anticoagulate them by heparin. But what's interesting is the autopsies showed systemic thrombosis in 70% of children who died after ECMO. So possibly we are not anticoagulating, it's suboptimal anticoagulation could be one of the contributing factors. So in health, the endothelium and the various plasma factors play a key role in maintaining normal homeostasis with a good balance between the procoagulants and anticoagulants. However, when the balance is disturbed, that's when you get clots in the wrong place, and this is often due to infection, inflammation, or contact with artificial surface. So when we instigate mechanical circulatory support, the exposure to the ECMO circuit, the tissue damage, combined with the underlying disease process, kind of triggers a cascade of inflammation, coagulation activation, cytokine storm, immune dysregulation, and endothelial dysfunction. So in simple terms, so you're going to put someone on ECMO and draw out all the blood into a plastic circuit, you're going to clot. And that's why you need an anticoagulant to stop that from happening. However, there are challenges, especially in pediatrics. The smaller circuits, low flow rates, and then the hemostasis is very immature, and you have antithrombin 3 deficiency, there is heparin resistance, and there is consumptive coagulopathy and the ECMO-induced coagulopathy. Acquired von Willebrand syndrome is something which is being described and has been recognized to occur in all the ECMO runs. So this is essentially, high molecular weight multimers of von Willebrand fracture is damaged or lost because of the high shear stress. So that affects platelet function and causes bleeding. And this is often not fixed by giving platelet transfusion. So the primary hemostasis, as you know, is by platelet activation, and the secondary hemostasis is by clotting cascade and the clotting factors. However, in neonates, the platelet function, the adhesion, aggregation, and the activation is immature and is different to that of adults. And the clotting factors, including antithrombin 3, the protein C, and the protein S, are half that of those measured in adults. So there is a problem there. So here we are in the vicious cycle of coagulation, inflammation, consumptive coagulopathy, combined with systemic anticoagulation, which leads to impaired hemostasis. And we as clinicians are anticoagulating these critically ill patients in such a complex circumstances. So the margin for error is probably very small. So how do we do it? So heparin is still the most extensively used anticoagulant till date. And I was looking at this paper in 1918. Heparin was first reported, the use of heparin was first reported in 1918. 100 years down the line, we have still not cracked or found a better anticoagulant than heparin. But heparin is cheap. It can be easily titrated.
It has a short half-life, and monitoring tests as well as antagonists are available as in protamine. And heparin acts by combining with the antithrombin 3 and also combines with the tissue factor pathway inhibitor. And the heparin-bound antithrombin 3 is 1,000 times more active in stopping the clot formation. And heparin also increases the affinity of the tissue factor pathway inhibitor to factor 10A, and it makes it inactive. However, it also binds to other plasma proteins, and that's why the pharmacokinetics can be variable and patient dose response is variable as well. And the pharmacokinetics varies also because the antithrombin concentration is low, there is relatively larger volume of distribution, and there is increased rate of clearance, especially if you're giving a furosemide infusion or putting them on CVVH or dialysis, things like that. And the half-life is much smaller in neonates. And heparin-induced thrombocytopenia, it's mostly in the adult world. We rarely see in the pediatric world. So practical issues are the amount of heparin you're giving, the amount of heparin in the blood, and the heparin activity, they are not the same. So an international survey looking at the anticoagulation management across 187 ELSO centers showed that the practice is highly variable. And more centers are moving towards multimodal monitoring to include anti-10A, TEG, and ROTEM into their armory of coagulation tests. If you look at there, you can see that the heparin is extensively used by all centers, and 8% of centers reported direct thrombin inhibitors. And 65% use anti-10A testing, 80% test for antithrombin 3, and 40% use thromboelastography or the viscoelastic test. So ACT is the most traditionally used test, and is extensively used with the experience extrapolated from cardiopulmonary bypass and cardiac surgery. However, I would like to say that ECMO is not bypass. So we do need multimodal monitoring, looking at the various aspects of the coagulation pathway and the clotting dynamics to be able to manage anticoagulation on ECMO. So what we have is a standard coagulation test, then you have the viscoelastic test, which will give you more information about the clotting. And we also look at the consumption markers like fibrinogen, D-dimers, LDH, and haptoglobin in some centers, and also monitor antithrombin levels, hemoglobin, and platelets. So ACT is, as I said, the best part of it is it's a bedside test, and it can be done quickly. But however, it doesn't depend only on heparin. It also depends on fibrinogen, platelets, hematocrit, etc. But it still has a role because it gives a global overview of the hemostasis. And APTT does measure heparin effect, but it is influenced by coagulopathy, and some still question the reliability of APTT in a very sick neonate. And then we have the anti-10A assay, which is the gold standard and the most sensitive for the direct action of the heparin. However, it's a time-consuming test, it's a chromogenic assay, and it can be affected by plasma-free hemoglobin levels, bilirubin, and lipids, high triglycerides as well. So, Liveris et al. Looked at the correlation between the heparin dose and the ACT. There's hardly any. And a few years ago, while I was working, in my previous job in UK, we introduced anti-10A into our pathway and collected some data. And that's reflected in our data as well, that there is poor correlation. And even the APTT versus heparin is not great either. Similar reflection in our data. And then you have better correlation of anti-10A to heparin, and somewhat similar in our data as well. Then coming to the ROTEM, ROTEM is a viscoelastic test. It gives you more information about the global dynamics and the kinetics of the anticoagulation, and it identifies defects at the various stages of coagulation, as in factor deficiency or fibrinogen shortage or platelet dysfunction or the heparin effect, the clot strength or the fibrinolytic effect. So it essentially rationalizes the use of blood products, and it's more useful when there is bleeding on ECMO. So let's look at the role of the antithrombin 3. So antithrombin 3 is a glycoprotein produced in the liver. It's an endogenous inhibitor of activated clotting factors, and heparin combines with antithrombin 3 and it potentiates the anticoagulant effects of the antithrombin 3. But however, it's lower in neonates and infants under 1 year, and as the ECMO runs are longer, you develop acquired antithrombin 3 deficiency because of the accelerated consumption and reduced synthesis. So AT3 deficiency is what leads to heparin resistance and potentially thrombosis. And some of these formulas help in correcting it, and some units aim it for about 80%, and some units about 100%, and some just over 50%. Stansfield et al. In their retrospective case series of 162 patients showed that the AT3 group had much less thrombotic and hemorrhagic complications, and also less transfusions per day and much higher anti-10A levels in the AT3 group. However, the same results have not been shown in the pediatric and the older children and adults. So what do we do at SKMC? So we usually start at the time of cannulation, after assessing the baseline coagulation of the patient, if the patient's already on heparin, and based on that, we give a bolus of 50 to 100 units per kilo of heparin, and we check frequent ACTs, and once we are happy that the bleeding ACT has come down and the bleeding is not an issue, we start at an initial dose of 20 units per kilo per hour. And the way we titrate the heparin, it depends on whether the patient is bleeding or is a standard patient or there is a clot risk. And then we adjust the heparin in 10 to 15% steps, up or down based on the parameter, using this normogram. So initially, the frequency of ACT is higher, and as we reach the steady state, we reduce the frequency of the ACT, APTT, and anti-10A. You require more frequent ACTs when there is bleeding or thrombosis or during weaning. And anti-10A is the most influential parameter in guiding the heparin titration. Otherwise, if you do it with ACT, you are going to, make a yo-yo effect on the heparin infusion. So in addition, we check antithrombin 3 levels, usually daily, but in neonates, sometimes we do Q12 hourly. As with anything in medicine, you got to interpret your tests and results in the context of the patient's clinical status, and in ECMO, in the context of the circuit as well. So the strategy should be tailored, and if there is a difference in the parameters and if they are not marrying up with each other, you look at the clinical status and the circuit status and follow the thing. For example, if your anti-10A is low and APTT is high on a patient who is bleeding, who has clots all over the circuit, then you try and optimize the anti-10A. But if you have an anti-10A which is low and APTT is high in a bleeding patient, then you try and reduce the APTT. So it's just have to, tailor it according to the patient needs. And then if you have clots in the circuit and if your D-dimers are going high, you should consider a circuit change. And we monitor plasma-free hemoglobin, and because it has a deleterious effect on organ dysfunction. And the easiest way of monitoring plasma-free hemoglobin is looking at the difference between the blood gas hemoglobin, which gives you the total HB, and lab HB, which is your intracellular hemoglobin. So this is a patient who I looked after in UK. Is a 15-year-old lad with sepsis, ARDS, hypoxia. We initially cannulated him peripherally through the groin. However, the patient was not getting enough flows and was hemodynamically unstable, so the chest was cut open and was put on central cannulation. However, he had an emergency fasciotomy because he developed a dissection of the femoral artery, a compartment syndrome, and the repair of the femoral artery. This patient had 10 liters of blood products in the first 48 hours ECMO. And this patient is doing well and goes and gives lectures about ECMO all over UK. And he's 22 now. Bleeding is quite significant, and it's been reported up to 60 to 70% of children and adults. And the most devastating complication you're worried about is the intracranial hemorrhage, which is reported in is about 16%, thankfully, only 16%. So if the patient is bleeding, you lower your targets, you aim for a lower mean arterial pressure, you keep the ionized calcium higher, you increase the thresholds for your platelets and the fibrinogen, consider ROTEM and look at what products you can transfuse, and consider stopping or reducing heparin and stopping heparin, and you use hemostatic adjuncts like tranexamic acid or very rarely a factor 7A, and consider massive hemorrhage protocol if the bleeding is torrential. And exploration is urgent exploration indicated if you have a tamponade or high volume of blood loss or continued blood loss despite you have normalized the clotting and with a normal ROTEM. Beware that once you stick your knives in, there might be more bleeding, so be prepared for that. So this is a review of the US database for looking at ECMO patients over 6 years. They had nearly 8,000 children, nearly 60,000 days of ECMO run, and platelets were transfused on 49% of the ECMO days, plasma 33% of the ECMO days, and cryoprecipitate 17% of the ECMO days. So they do consume a lot of blood products. And the same paper quotes that use of hemostatic agents, tranexamic acid, 22% of the patients, aminocaproic acid, 7%. These are fibrinolytics, and factor 7A in 3% of the patients. I've only used factor 7A in 2 patients, and this is a paper which shows about 17 patients where they used, and they've shown a dramatic reduction in the chest tube drainage and the blood product usage However, there is a risk of circuit clotting. You should always have a standby circuit in place and have an MDT before giving this 7A. So looking at the heparin alternatives, so direct thrombin inhibitors like bivalirudin and lepirudin combine or basically bind to the thrombin which is circulating as well as the clot-bound thrombin, which is a fantastic thing because if the thrombin is binding to the places where it's clotting then it's going to reduce the clots even more. And it is independent of antithrombin 3 and does not cause heparin-induced thrombocytopenia. However, there is no antidote, but the advantage is that it has a very short half-life, and there are suggestions that in the low flow states, it can cause intracardiac thrombosis and things like that. And this is the paper looking at comparing bivalirudin versus heparin in both adult and pediatric ECMO. And what they have shown is the survival was much better in the bivalirudin group. And the authors introduce a concept of what's called immunothrombosis, What they say is thrombin activates the platelets, the endothelium, and the innate immunity, and the direct thrombin inhibitors block this, so the inflammation and immune dysregulation is lower, and that's probably why they think the survival is better, although the ECMO days, the length of the hospital stay, and the complication rate was similar in both the groups. It's interesting. And this is a pediatric case series of 32 patients in post-cardiotomy ECMO, where they showed the survival was better in bivalirudin group, and neurological events were lower. And this is a systematic review and meta-analysis of bivalirudin DTIs versus heparin. So the forest plots favor the DTIs in both mortality and the major bleeding. However, due to lack of RCTs, the certainty of this evidence is low. So what does the future hold? We do need more evidence on DTIs and maybe better anticoagulant than heparin, or maybe we need to research for regional anticoagulants which only act on the circuit but doesn't affect the patients. And there's more research into new novel circuits, adding nitric into it, fluid repellent surfaces, endothelializing the circuit, etc. So in summary, optimal anticoagulation on ECMO is still a challenge. Heparin is still the mainstay. Multimodal monitoring rather than focusing on one test is key. AT3 supplementation, particularly in neonates, can reduce the heparin resistance. And beware of the acquired von Willebrand fracture syndrome. And happy National Day. And we'll talk about the football in lunchtime. Thank you.
Thank you, Dr. Naga. Questions?
Yeah. I'm always interested in anticoagulation, right? So do you have antifactor 10A level measurement in SKMCA?
Yes.
So what is the turnaround time for having anticoagulation monitoring for ECMO patients in your ICU?
I think it's actually, our labs are pretty good with anti-10A, and we do have a turnaround time of, mostly APTT and anti-10A comes back somewhere between 45 minutes to an hour.
So you have very good chemistry with the lab.
Yeah.
All right.
Because we don't have many, correct me if I'm wrong, Mark, but we don't get a lot of ECMO patients all the time, and especially the last year we had very few runs. But yeah, our turnaround time is not bad.
Okay.
So SKMC already has a system of prioritizing for ECMO patients. Once the patient is on ECMO, we let the lab know. The lab, as soon as they receive a sample, the turnaround time is pretty quick. Even for Group G, we made agreement with SKMC for anti-10A for a turnaround time of 2 hours. So it must be much quicker.
Oh, it's much quicker.
Because, I was in the past when doing ECMO practice, so we were pushing for ECMO patients to have stat labs, but, still turned to be very slow. So this is very good.
I have a small comment. Regarding the ACT, I was wondering if the intensivist will be staying patient and tuned just not to do too much ACTs, because the machine is at bedside and there will be always curiosity and interest to do more. So when you tell them just do it every 2 to 4 hours, and even in Euro also survey, people are just doing it twice a day or so, if there's no bleeding or clotting, because as much as you give blood product, there will be false results of ACT, and then you're chasing your tail or you're doing the yo-yo game. So I'm extremely fan of doing less ACTs if you have anti-10A with a good TAT, and especially if the lab is really aware about doing anti-10A for the heparin, for the unfractionated heparin rather than for enoxaparin, because that was a challenge in my center that some juniors biochem technicians, especially overnight, they will do it for the enoxaparin and not for unfractionated heparin. Then we're utilizing the system just to reinforce this is an ECMO patient and they should do it this way, and we're doing the memos and teaching for them. So I think it would be very helpful to minimize the labs unnecessarily, because you may just overdoing it for the kid or do things unnecessarily and things goes off. Thank you.
Yeah, very good comment. Thank you.
And I believe the ACT is just, for the duration or during the cannulation and just after the cannulation for a few hours till you settle down. After that, there is no much, accurate information will be provided by the ACT. Just going back to the factor 7, we had used it only one time during my fellowship in Canada only. So for a patient with, continuous bleeding on the ECMO circuit, should be given carefully with full supervision by the cardiac surgeon or the cardiac intensivist. And it will be just, a mini dose, is not the therapeutic dose which is given for bleeding patients in post-trauma.
Brilliant, thank you. So just to respond to that comment about the ACT, the frequency of ACT is much higher when we initiate the ECMO and also during the dynamic states of bleeding and things like that. But once the patient is stable, we reduce the frequency down to 8 to 12 hours as well. It all depends on the patient status. And coming to the factor 7A, in my limited experience of ECMO, I've only used twice. One patient, it was desperate, the patient died anyway, and the other patient actually did well, but we had to change the circuit a day later.
Okay. Just one comment, I think we're all getting it wrong. ECMO doesn't cause intracerebral bleeding. 2 reasons why I say that. One, we've got case law locally in Leicester where the coroner tells us that because she was fed up with doing investigations for deaths with intracerebral hemorrhage. But on a more scientific note, I think Alan Coombs showed in his study, one of the good things to come out of that was that the incidence of intracerebral hemorrhage was higher in the control group than in the ECMO group. What causes intracerebral hemorrhage is being sick enough to need ECMO. So don't be scared of it and go on it. And there isn't an easy answer.
Yeah, that's a good point.
Okay, thank you, Dr. Naga.
Thank you.
So now I'd like to introduce our next speaker, from Dr. Naga to Dr. Nada. Dr. Nada comes to us from Riyadh. She had a fellowship critical care in McGill in Montreal and has had extensive cardiac and general ICU experience, and now she's the Pediatric ECMO service line lead at the Cluster 2 hospitals in Riyadh. Thank you, Dr. Nada.
Thank you. While the slides are setting up, thanks for the invitation and thanks for the introduction. As of any technology in the ICU, the moment you put patient on something, you need to think when I'm gonna take it off. So when you put patient on mechanical ventilatory support, you think when he gonna be ready for extubation. So moving for the ECMOs, the outlines for that is assessing patient on VV ECMO and their readiness to take it off is important. We're gonna explore the methods of weaning and goes for the steps of weaning to be ready for the decannulation, which is very challenging when it comes into you had very rough time to put patient on ECMO. It's not easy just to take the cannulas off because reinstituting the ECMO in pediatrics is going to be extremely challenged. And then decannulation decision and who will be taking the lead. So the intention, as I mentioned, in ECMO in children is to wait for the lungs to heal and that disease to improve. Because you have different pathophysiology, different indications for ECMO, therefore not all kids they will go in 5-7 days of ECMO. So it might be sepsis that take long time, or might be a neonate who had an event and it just take less time. So it is variable, depend on the disease process, and taking the patient from one white out X-ray to improved aeration will take time, so you just gonna stay patient until the native lung take the lead while you are fully supporting the kid or the patient with the membrane lung through the ECMO. So how do you assess for the readiness of taking off the patient from that support? So first of all, you just go for IMPROVE, which is the protective lung strategy on ECMO, and waiting for that time with that settings, with good blood gases. People need to be really patient because some people will just say, okay, let's recruit the lung, well, let's try to do 1, 2, 3. No, you just need to be a few days having no intervention and just being patient until you see some changes improve with the same settings. With the same protective lung strategy that you are putting your patient, you will find some aeration getting day after day, plus you will find improvement in the compliance. For the same tidal volumes, you have less pressure, or same pressure, you're having better tidal volume. So that's the improvement phase during the ECMO support. The second, the gas exchange. Well, my settings were the same yesterday and today, but today I have better PaO2 and I have better CO2 exchange. This will tell you two things. As the time passes, you have two things. Well, first, patient would need less support after the days pass because of the improvement of the lung disease. At the same time, they're just presenting themselves that we are ready to be weaned, at least weaned. But the challenge is taking it off trial will need some extra tests to go for it. So to say that my patient is ready, I need PaO2 that is good enough, above 60, and I need less pressures with less oxygen. I'm not going to push the lung with FiO2 above 80% and increasing their mortality just to take the ECMO off. Then why did you put it in the first place, right? So the second is peak pressures. If you're going to hammer the lung again just to take him off ECMO, you better not do it. Continue hammering, don't put ECMO. Either we do things right at the end of it, as you started with a good indication, you just stay patient and control the complication, optimize the anticoagulation and manage it very well until you are ready for the taking it off. Few methods on ECMO weaning. So it's different institution, different strategies, but the commonest that I have observed in the centers is weaning the ECMO sweep gas. So weaning the ECMO gas through the sweep gas and the FDO2, the inspired oxygen and the device oxygen such availability, and you maintain the same ECMO flow. So if you consider the blood flow on the ECMO a constant, decreasing the oxygen, decreasing the sweep gas will be the variable things to challenge that patient if he can be off or not. The other strategy is other centers would use weaning the ECMO flow because we assume it's a constant, but it's really variable depending on multiple factors. But it's very challenging in pediatrics because you cannot wean the blood flow that easily because you started with a very small amount. It's not like 3-6 liters in adults. It's just a liter or less in small children. And this will be challenge in optimizing the anticoagulation or waiting for a long time to decide that the lung is really absolutely recovered because it's a challenging organ. Also, it's not like a heart. Frank failure will appear in no time. However, the regardless the use, I would just focus on one method, which is weaning the sweet gas, because it will be easier, and this is my comfort zone to use. But anyhow, the way of weaning the sweet gas or the FiO2 on the device is again variable. People will do 10 minutes, 15 minutes, 1 hour. I would do 12, 24 hours, but that particular protocol has to be clear for everyone. So with changing service, nurses will not struggle, perfusionists will not struggle. Have a protocol in your place and say, this is the way we're gonna do it. So if you're gonna do it in one way, people need to stick to it to know that patient deviated from the success targets, or he is or numbers are encouraging just to move forward. So what is the oxygen test that would determine that the patient is really succeeding the ECMO weaning? So while we are maintaining the same blood flow on ECMO as I mentioned, the oxygen FiO2, the FiO2 will be increased to 100% for 10 to 15 minutes, and then do blood gas before and after that period of time and compare it. If the PaO2 increased markedly while the patient on reasonable mechanical ventilatory support, FiO2 less than 60%, the rate is reasonable, the tidal volume is reasonable, my pressures are not exceeding like heroic numbers like 25 or 28, then you say, okay, my patient is ready. There are few protocols published in adult literature, and many of them are using kind of pathway to help, as I mentioned, the team to say, okay, I'm ready to wean or not. So, for example, this protocol is going through kind of a checklist. Is the lung ventilation safe? Am I able to ventilate with the safe numbers, safe pressures? If yes, okay, so the saturation is optimum, above 90% or above 88%. If yes, then weaning the sweet gas while monitoring both oxygen and the CO2. And if the weaning successful all the way until the sweep is off, and then they are waiting while the oxygen is off, sweet gas is off for 12, 24 hours, maybe 48 hours. It depends on the place you are working on, but it is optimum to wait for 24 up to 48 hours. As I said, it's not easy just to remove the cannula, especially if you are maintaining the blood flow with optimum anticoagulation, you are safe. And at any time patient had an issue, you can't just go back. So just to make it summarize, as I mentioned so many things, assess the baseline ECMO settings. Are you in very high settings or reasonable settings to wean? Assess the mechanical ventilatory settings from resting toward increasing it day by day, and then check your values and indicators. Is oxygen 100% trial test is enough to tell me my patient is ready? In the literature, there is one article to review that question, and I find it interesting to say, no, it's not enough. So it's not about oxygenation. Sometimes the indication was hypercapnic failure, it wasn't the oxygenation. So even though you had an oxygen pass, you need to assess the minute ventilation, the dead space on that patient, and his gas exchange from the CO2 perspective. So discuss the decision of eligibility about this patient to be taken off among your team, and increase the parameters gradually while you are doing the challenge to go off off ECMO. So VV ECMO weaning, the process, as I mentioned, is variable. Why do I mention this point again? Because I need to highlight one thing. When you are assessing that patient is successful to do the weaning, you need to start actively to work on that lung and optimize it. This is the time you think more about the recruitment and need for bronchoscopy, the need of optimization of the lung, because yes, I agree, white out lung for a few days or even weeks will not be super good by the time you are just waiting for the lung to show some opening up, but there is a routine management during ECMO, like routine suctioning or routine recruitment in some center. But as you are passing a certain period, you need to be more proactive on that. And intensivists will assess the ventilation, pressure, volume loops to check on the compliance, and other blood gases frequency will be even higher. Assessing also the vital signs and education and patient tolerance to that weaning is very important. It's not about numbers only, it's about the patient response to that. The trial of support in discontinuing the sweet gas, worth mentioning one thing. Some perfusionists will tell you why you are off sweet gas for 6 hours. They're not happy with that, so they will ask for flushing of the oxygenator every now and then with some air. They call it cuff maneuver, and this is just to have a better wash out of the mist, and in case you go on ECMO, it will be really oxygenator with optimum setting. This is another protocol that is published in the literature. It's with the same strategy. Once you initiate, think about the weaning, and you go through certain process or pathway with very helpful guide numbers. In adults, it will be very helpful to replicate that for pediatrics to have one pathway. Other points. It's not a routine to put all patients on inhaled nitric oxide when you go off, unless it's needed, unless it's an emergency. Because weaning can be just as an emergency. I have to go off ECMO right away, and you go for optimum lung ventilation, optimum oxygenation, using other methods just to help to take off ECMO, regardless whether you're going to go back to it or not, but you are pushed to do that. The second part is some people think that having patient on room air with the sweet gas, let's say 1 liter, 2 liter ECMO flow, 1 liter sweet gas, and a FiO2 of 21%. They think that degree of air still may do gas exchange. That's why they go for cap off, totally off, discontinue the gas from the oxygenator. Well, that's also mentioned. Okay, so moving to decannulation. If the trial succeeded and you are happy to do decannulation, you need to think about a certain way of getting your team ready. So if you have a protocol, I would always go for checklist or guidelines for my team to be prepared. So I did this PEM. It's kind of difficult even, but it's easy to go through the steps. Briefing with the team. We did the test, we succeeded in it, so let's prepare. Who are the personnel who need to be around in the decannulation? If the surgeon did the cannulation, then you go with the surgeon. If it is intensivist, you need a backup support or not. If it is percutaneous or surgically, where is the settings you need to decannulate? It's almost the same place for people, easy to same steps whether surgically inserted or percutaneously, but there are a few points that you need to consider. Prepare your PPEs and all the equipment needed. So for patients, he needs to be optimal, right? So we mentioned about the gas exchange and the blood gases frequency. Airway is optimized, lung are optimized. What else? Hemoglobin, as carrying capacity for the oxygen need to be optimal. As you're going to remove the cannula after off heparin, you need to consider that you are at optimal coagulation status, hemostasis status, so you will not have bleeding or other stuff, and adequate mechanical ventilatory support. The patient position also needs to be optimal, having an access at that time. Equipment-wise, it happened that you are ready and the surgeon is ready, then people are shouting around, where's that suture, where's that scissor, where's, so just do your own checklist, be prepared for all the equipment you need at the time of decannulation. Medication is very vital. You don't need a patient to be awake. Even if he was on awake ECMO, it's time to sedate him and probably paralyze him just to remove the cannula smoothly without problems. So some patients are ready to decannulate, but because of some very tiny thing in your checklist, patient is agitated, air entertainment, and you lost the patient because of some air embolism, it's not fair, so just to optimize that as well. Rarely you would use protamine or if the patient was anticoagulated with heparin, if you are 1 to 2 hours off, probably 30 minutes is enough also, just be extra cautious. The different techniques have been used. You just need to make sure if it is percutaneous cannulation that you have enough sutures around the cannula to pull it while you have prepared suture around to close that gap in no time. Okay, so in cut down. So a few steps in the cut down need to be considered. Rarely you would need vascular repair for the vessels unless people are not sure. But I just want to mention something important about percutaneous cannulation technique, that you may have complications that you are not aware of. So some cases has been shared in some of the conferences that you did percutaneous, everything was all right, but that cannula was traveling from vein to artery back to vein in a very strange way. But it's very helpful to have adequate images before and after from if it is in the neck, to have an echo. We all probably know that there are some patients who have reactive pericardial effusion, but just make sure that you don't have perforation somewhere else. If you remove this cannula, there will be catastrophe post decannulation. Having surgeon as a backup is needed if it is not backup. Having the surgeon to remove the cannula if it is cut down is necessary. Having vascular surgeon as a backup may be necessary in VA ECMO more than veno-venous, but I always give them a heads-up call that we are decannulating in case things are off, and once the sutures are maintained, we do ultrasound on the skin just to see that the vessel is intact. Post-decannulation care. We are celebrating ECMO is off. If the child is doing well, then that room has no personnel around. It's like the end of the day. This is where we need to pay the extra mile have been mentioned, and we need to give more care for the pulmonary hygiene therapy, for the gases, and monitoring of the volume pressures of that patient, and as well as do the vascular access. My last slide is about the complicated scenarios. Well, we don't want to end the long morning with bad stories, but I'm just going to give heads up about the tearing of the veins, complete division of the veins that would need repair, or you don't have enough stump after cut down to control, so a vascular or cardiovascular have to take that off, especially in the long ECMO run, and the emergency decannulation that I have mentioned. Well, patient had pump, the ECMO pump has clotted off and he has DIC induced by ACLS. You need to take it off, patient is bleeding everywhere. So lung is not ready, but you have to do something. You have to go all the way to the medical intensive care of that lung using high frequency nitric oxide, whatever it is as possible to oxygenate, to take the ECMO off at that time. Some kits you will be able to reinstitute ECMO, some are not, depending on the way of cannulation and the needs. So that's only the main references, others I've mentioned in the slides, and thank you. Any questions? No questions, great.
The weaning from VV ECMO, so we have mixed experience and with that. So sometimes we extubate first and we keep the VV ECMO as a backup to make sure things are okay. Then we wean off totally ECMO. Or we just decannulate the ECMO, especially when there is a risk of bleeding or thrombosis, just we take it out and we stay with the mechanical ventilation. So what do you do in pediatrics? Because we have different experience than the adults.
Well, it's almost the same, but just re-emphasize on the question, right? Directly for the pediatrics. Can you re-emphasize on the question, please?
Which one is your strategy for weaning that you use? Extubation from mechanical ventilation, then wean the ECMO, or wean off the ECMO and then extubate?
Well, absolutely, we wean off the ECMO. So in majority of, well, all of the cases that I have encountered were intubated children. Only one kid was extubated, and he had like brief spontaneous breathing, and he was intubated when he was closer for the weaning of ECMO. Intubated, bronchhed, optimized the airway and the lungs, and then we weaned the ECMO. So other scenarios, which is the safest to do, is patient is intubated on mechanical ventilatory support, and you wean off ECMO until it's totally off, a few days after you assess for the weaning of mechanical ventilation to extubate. Well, my question to you will be, Dr. Salman, is if the patient is awake, walking around with ECMO, and he's on nasal cannula, would you just do conscious sedation to remove the ECMO as an option, or you do sedate, intubate to remove the ECMO? Well, he was doing well.
Well, conscious sedation is, the best approach, right? So we just explain to the patients about the procedure of decannulation. Okay, give some just little painkillers to make him comfortable, and then we proceed with the decannulation. I have attended only twice for patients who are awake on ECMO, and we remove the ECMO cannulas. Otherwise, I haven't seen this scenario often.
Because I came across the same scenario where they were instructing to sedate adequately, explain to the patient, intubate to remove it properly, especially after prolonged ECMO, because most of those walking and talking are prolonged ECMO, anticipating the problems that can be managed better way, like especially for the vascular access, having them sedated and quiet for 24 hours has no harm. But interesting.
I had seen, one patient with kind of post-traumatic, feelings. So he was depressed, and he was having also an anxiety when you are coming to wean the mechanical ventilation. And he was actually refusing to disconnect the mechanical ventilator as well. He was so ready. So what I was doing is just keep 5/5 pressure support and PEEP, and I just came down to 24%, then 21%, and never informed him that he is almost off ventilator. And after that, after one day almost, I explained to him that the mechanical ventilator was just, kept off, just like a placebo, to, crush him that he is ready for extubation, and he is ready to go on, without any support. So we'll feel that, if you want to wean, the patients, they will be reluctant for weaning. It's kind of phobia, and you have to manage this phobic, reaction by some psychiatric medications, and sometimes you have to behave different with the patients. Do your cheating maneuver, all right?
Perfect. That's the message of today.
Well, I did it with him, and after that he was, shocked. I told him, okay, you are off everything since one day, and I'm just removing everything.
Yeah, we've seen similar where as soon as your patient sees you disconnecting the sweep gas, they get agitated and panic. So you've actually removed the circuit to behind them, taken the sweep gas off, and they don't notice, and they come off. So it's an interesting thing that people get attached.
You see, children are easier in that context.
Oh yeah. And the easiest route to get awake on newborns, you can have them wide awake on ECMO waving. In fact, I always offer that to parents to say, oh well, you'll see your baby's eye open for the first time. But yeah, local anaesthetic works. today, for VV at least.
Interesting.
I wanted to ask about, do you routinely do echocardiograms, look at any echocardiographic parameters in VV ECMO?
As a management day by day or upon weaning?
No, I mean just before weaning or when you're thinking about decannulation.
Yes.
Do you routinely
Well,
do it?
yeah, sure. So in VV ECMO in adults, it might be more rational because of the RV failure and the effect on VV ECMO specifically, but that also happen in pediatrics. So I do advise for echo for two things. First, localizing the ECMO cannulas, which is day 1, day 2, but even after week by week, you may just forget about it, and the cannula in place for a month. Migration complication chances gonna be just increased. So if it's not every week, I would ask for routine echo before the decannulation. Assessing the pericardial effusion and the RV is very helpful. Thanks so much.
Thank you, Dr. Naga. Wonderful talk. Thank you.